All right. Good morning, everyone, and thank you so much for taking time out of your day to join us here for our live webcast for April 2026. It's my pleasure to welcome you to the Cardiac Cath Lab here at Mount Sinai Hospital in New York. And it's my pleasure to moderate from here along with our two guest moderators who have made time from their schedule to join us. But before we introduce them, let me introduce our team here. To my left here is Dr. Vishal Kapoor, who's the director of Mount Sinai Morningside for Endovascular Services. To his left is Dr. Rahul Patel, who's the associate professor of diagnostic and molecular radiology here at Mount Sinai, and you guys have seen him multiple times help us with these very, very difficult cases. Behind him is we have Michael A., who is one of our endovascular fellows. We have 3 fellows this year, and our nursing team today is Mark and Denisa, and our techs are Damien and Freddie, and as always, they've been incredible in our help. And I'd also now like to welcome our 2 guest moderators who really, like Rahul, need no introduction. We have Dr. Kumar Madaseri, who's the Associate Professor of Interventional Radiology at Rush, and we have Srinivas Tamala from Florida Vascular Associates and formerly from the University of Miami. Srini, Kumar, thank you so much for joining us for this very difficult case, and really appreciate both of you taking the time to really help us and educate everybody who's online. Thanks again, guys. So without further ado, we're going to have our fellow Michael present the case. We've got a wonderful case to show you. Mike?
Slides, please. Thank you. Good morning, everyone. So we have a case of an iliocaval reconstruction today.
Let's say next slide.
Next slide, guys. Oh, there you go.
So the patient's a 58-year-old woman, a history of chronic venous insufficiency, CAP class 6, with persistent bilateral lower extremity cramping, heaviness, edema, and a right ankle venous ulcer that is not healing. She's been complying with all optimal medical therapy, including compression stockings, pumps, elevations, but she's severely limited in her activities of daily living and also has this non-healing ulcer. So as far as her past medical history, we mentioned she has venous insufficiency, has had ablations in the past. She's a diabetic, hyperlipidemia, hypothyroidism. As far as her social history, she did quit smoking 6 months ago, had a pack year history for a very long time, no alcohol or other illicit substances. And those are her medications. So this is the CT venogram we had.
Does it play?
Yeah, when I start playing it, there you go.
Mm-hmm. Maybe Rahul, you can discuss it.
Yeah, so you have the CT venogram here. It basically shows the suprarenal IVC is open, the infrarenal IVC is out. It looks like the commons are out too, and then the external basically are open on both sides, and the common femorals are open. So basically, a true iliocaval, infrarenal IVC occlusion.
Got it.
So this is her initial diagnostic venogram. We can probably show the pictures we have, but similar to what the CAT scan showed. Mm-hmm. And you'll see a lot of tributaries kind of coming across there. That's a shot of the left. You can see the commons occluded there.
All right.
Go next slide.
So why don't we just stop there before you get to the thing, and let's talk about traditional ways of fixing it. I mean, Kumar, Srini, any comments on questions about what we're going to do and what you guys would do in this case?
Go
ahead, Kumar.
Chronic occlusion, you got some really well-formed collaterals, but in the setting of non-healing venous ulcer, I'm assuming there's some PTS changes, edema and stuff. I think you have to kind of go at this. One of the things in this area when you want to be crossing, trying to figure out how to navigate through these occlusions, is going to be making sure you're looking at multiple planes, because it's very easy to go off kilter here. So I think using like a coaxial triaxial system is what I would do, and it sounds like common femorals are open, so I think you have great starting points to attack from both sides, and I would start with the neck axis ready to go as well.
Srini, anything?
Yeah, not much. Yeah, not much to add. I think you definitely have a good indication here to tackle this. I think, oftentimes people will use, triple access here, jugular, both groins if needed. I think the status of the deep femoral vein is very important. That's your inflow, and that really helps improve patency rate, especially once you've reconstructed the IVC. And like Rahul had mentioned, really seeing whether it's juxtarenal, suprarenal, or infrarenal, what segments are involved is really key to when you're deciding on where to deploy your stents.
Got it. Rahul, what was the traditional way you guys would fix this normally? I mean,
Yeah, so it's kind of like Kumar said. Basically, it's catheters, wires, cross, balloon, and then stents. I
at
think
that time, what did you do before you had it?
that's what's changed. So I think when I was a fellow long ago, there was wall stents and then smart stents, sort of non-dedicated venous stents, which worked, but had their own sets of issues. We're sort of now in an era where we have dedicated venous stents with better radial force and don't have sort of some of the idiosyncrasies that wall stents have. And now we have even newer stents like the Gore stent, which we're going to end up placing today. The other thing is, we did a lot of this stuff without a lot of data. I think not that this patient completely fits into that category, but they just presented the C-track data, which was just published in the New England Journal of Medicine a couple of weeks ago, which shows that the patients who have iliac vein occlusion, you can sort of extrapolate if they have on top of it IVC occlusion.
You got that presentation, right? Or no?
Yeah, on top of the IVC occlusion, that these patients should get reconstructed to prevent PTS, and they do better than just medical therapy alone.
Yeah. So I guess for Kumar and Srini as well as Rahul, like which patients do you address this with? Do you have to have non-healing ulcers? Do you just edema, or is it just any IVC occlusion that you find?
No,
I think.
Yeah.
Go ahead. Sorry. Go ahead.
I think they have to be like anything we do. They have to be symptomatic. I mean, that's the bottom line. Whether it's a venous
And define
claudication,
symptoms,
edema, ulceration.
Okay.
So leg edema that persists despite conservative therapy, PTS changes, venous insufficiency, pain, discomfort, ulceration, venous stasis changes, all those things that are not improving despite conservative therapy. And also it's affecting their ADLs or activities of daily living and really affecting their quality of life. Those are true indications to intervene.
For me, it's more, if they have truly a venous ulcer that you've tried all the appropriate wound care with multi-layer compressions, you've done the lymphedema and stuff, that's fine. But, when it comes to non-ulcer patients with venous disease, I kind of treat them like how we're supposed to treat claudication. It's like, it's got to be a pretty quality of life limiting situation for them from a venous standpoint, because I think we all know the venous reconstructions, all these great things we do, they have a little bit difference in patency and how well they do compared to the arterial system. So I don't jump the gun on fixing every iliocaval thing if the filter's there. I think you really got to be sold on the venous aspect of how debilitating it is for that patient and what you can do to improve their quality of life. Yeah.
So last question for you guys, and I'm talking from an interventional cardiology perspective because a lot of us really don't do a lot of this work. So you talked about the older, even the new generation stents like the Abre and the BD stent and so on and so forth. So what was the limitation with that?
So just by the physics of stents, you can't make them bigger than what they are. So like 20 is about the limit they get, because once you get over that limit, the radial force starts to drop off, right? The other is, because of that, when you're trying to do an IVC reconstruction, 20 millimeter IVC is probably a little too small. So we basically were just double barreling up the IVC. And then what you would see is that you wouldn't get two circular lumens going up. You would get two Ds, right?
Okay.
Or the two oval shaped sizes. Or sometimes you'll get one just completely compressing the other. And so I think with this newer generation of stent, at least in our experience, and we haven't done hundreds of cases, but what we see is that you get those two nice round circles, coming down from the IVC down, and then they also go up to 28 millimeters. So I think that's super helpful in terms of trying to reconstruct these IVCs.
And Rahul, can you talk a little bit about your sheets and what you chose?
Yeah, so right now we're probably a little undersized, but we have a 5 French IJ sheath with an MPA down. Basically, we'll show you some images. If you go to the first run.
It's better than me.
So this is just getting access, and this is just an injection from the IVC. You can see basically the IVC is out. The left renal vein is sort of where the V is on the Viper track. And so that's sort of where the left renal vein is. So that's kind of our area of reconstruction. So that's the venogram. This is a bilateral venogram. So it looks somewhat similar to what they had, a little under-injected, but you can see that basically you still got sort of this chronic iliac and IVC occlusion. So you can kind of see like just the access wires kind of started going up the iliac. So we started with that. I can kind of show you if you want to go to the next cine loop. So this is from the left side. You can see what we're puffing. And again, sort of what Kumar said. You want to make sure you're in the right channel because you don't want to reconstruct the wrong channel. So then we go to the next. And this is just confirming that we're in front of the spine as opposed to behind the spine on this side. And so this is kind of where we've left it. So you guys can see sort of the reconstruction, unless you guys have other comments about how you would approach this.
No.
Rahul, let me ask you a question. Just from an anatomical perspective, suprarenal versus infrarenal reconstruction. What's your change in strategy?
It's not. It's still sort of the same. The other question, it begs the question is if you do have to go above the renal veins and have to cover them, is that a problem? And at least in the study from the Gore stent and then in other experiences from other stents, it hasn't been an issue in terms of compromising renal function.
Perfect.
Yeah.
So why don't we get started? Take a time and go ahead.
Yeah. So you can see, we're going to start with this side. So basically it's a 180 stiff glide, and all I'm doing is just spinning the wire and letting it go. You don't really want to double it over. You just kind of want to spin, spin, spin until...
So why not double it? A lot of people would try a loop technique.
Yeah, it's not quite like a... Sorry, I'm getting wrapped on the towel here.
Let me wipe it.
Yeah, thanks. Yeah, it's not quite like an arterial reconstruction, right? Like you don't want to double it over. There's no real subintimal lumen. Mm-hmm. At some point, some people, you get frustrated and you kind of try to double it over and see. But literally, it's just spin the wire and see if it goes.
And I notice you're not tracking the support catheter.
I will. If it doesn't go or if it starts to double over, then I'll try.
Got it.
This is just going actually pretty easily. So.
Good. Now, what's inside this? Is it fibrous tissue, Srini, or is it a Kumar, or is it thrombus? What are we dealing with here?
I mean, it's all of the above. I mean, that's why the CT venogram is very helpful, because you can see if you actually got a vein that's gone, right? It becomes a fibrotic scar versus a lumen with more subacute and acute thrombus. And so I think that helps you. I think in this case, this is probably fibrosis. Is what I imagine. What do you think, Kumar?
Yeah, no,
yeah, I mean, it's either Rahul's got incredible hands or the vessel's really lending itself to recanalization. So I think there's a fibrous component definitely there.
Yeah,
and I think one of the key things, if you notice, Rahul's doing obliques, because you can really end up retroperitoneal here and cause a real big problem. And some people have ended up in the spinal canal as while they're doing a recanalization. So it's real important to make sure you know where you are.
So Kumar, Srini, I mean, while Rahul's working, I mean, when you do this orthogonal views, what are you looking for? You're looking for the wire on top of the spine, like Rahul talked about, or anything else?
Yeah, I mean, anterior to the spine. He also has a target up top with that catheter. But sometimes we do home beam CT on the table, or we do hybrid angio CT. So you'd be really surprised with these big lumbar collateral veins that you get that I think you're going in the right direction. But having a catheter up top, just like we do in the safaris and the arterial procedures, you have a little bit more confidence. But definitely want to be in front of the spine, like Srini said. There's a few cases.
You're not going to the lumen now, all the way. Yeah, you're good.
Yeah.
Got it.
Yeah. So we're up in the IVC. So this is a 5 French Berenstein. It's probably not going to go because it's a little too tight.
Do you have
like a 4 Glycath?
Or you want a Navicross?
Or a Navicross.
Yeah, Navicross, guys, 035. That'll go. Short wires. You can give him a glide cath.
Yeah.
Glide catheter, 4 French.
So I find that once you cross one side, if the other side doesn't go, you can sort of balloon open the lumen, and then that usually helps the other side cross. So
Rahul, in the past when we've done this together, you cannulated the hepatic vein, right? In the past, if I remember right.
So that was one we were trying to figure out if we were going to do a suprarenal IVC.
So with suprarenal, it's important to do that.
So that's another question, right? So if you have to go up that high, if you cover the hepatic veins, is it a problem? It really shouldn't be, because that part of the IVC is really patulous.
Right.
It's pretty big. So if you have to really go into the suprahepatic IVC, is that a problem? I don't think it is. We try not to, just because we see a lot of like liver transplant patients and things like that. So having to do like a transjugular liver biopsy through a stent.
Give me a contrast injection. Right.
So Kumar, tell me about the role of IVUS here. Do you use IVUS in this particular case, Kumar? I know you use a lot of IVUS, as we all do, but I mean, I think you might use it more in the veins in this situation.
I think for when you have a chronic iliocaval occlusion, I don't know if I necessarily think IVUS is going to be the game changer. I think you have
the J implants.
Yeah,
the veins are. It would help you to think about your stent sizing at the top and bottom, especially since you have to reconstruct the cable. But in the middle of the occlusion, I don't think IVUS is as valuable.
Okay, Srini, any agreement, disagreement on that?
No, I agree.
Oh.
I agree.
How about you, Rahul? When do you use IVUS?
So in open veins, I use IVUS. In closed veins, I tend not to use IVUS until the end, just to make sure I have good luminal gain and that everything looks good, that's sort of when I use IVIS. Sort of kind of like what Kumar said.
So one of the things I want to ask three of you is you guys all said 3 accesses, right? So is it an alternate access in case you
start working on
fail?
the
Is that
left,
the
or you wanna
reason
start
why
doing
you
it?
have
Yeah.
the jugular access, or does that play another role that I'm not aware of on why are we doing that? Rahul, you want to take that?
Yeah, so again, I think it's just knowing where the target is.
Uh-huh.
Yeah, so she's feeling that, so we're probably not in the right spot.
Talk to her, guys. She's sleeping. She's snoring, or she's
Yeah,
feeling
so
it?
this side's gonna. I figured this side's gonna be harder.
Duele?
I think the reason for triple access,
She's
PK,
sleeping, guys.
which
Uh-huh.
I think most of us agree on, is that you may not get to where you need to go because you're dealing with long segment fibrotic occlusions, right? And so
Right.
you really need targets. Sometimes it helps as a target. Sometimes it helps as an
This
additional
wire's toast.
access
Can I have a
point
new-
to try recanalization from
Yeah, this
Give me the new
above.
glide wire.
Actually, we can take that other 180
That's
that we
really
used
what
before.
it's for.
No, we have the previous
it.
stiff angle glide. Give me the other
So
one.
as far as wires, do you guys always do
Right here.
0.5 systems? You go with 0.18 or
Mike, hold
0.14,
this,
or
hold it.
how do you guys approach it? You know, because obviously it's different than what we're doing in traditional
torque on
peripheral
this.
arterial disease.
That's weird.
For Iliocaval,
Torque on
often
this
it's
one.
0.35 for me. Rarely 0.18. I don't think I've ever used an 0.14 outside of some of their kind of weird sharp recanalization, but almost always you need the bulk and strength of an 0.35 size wire pretty much for most of these cases.
Got it. So okay, so very rarely 0.18, and always the glides are your workhorse on these kind of things.
Yeah.
Let's
Got it.
see if this goes.
Interesting.
Yeah, we may need to switch the catheter again. Yeah,
Prolapse on the other side.
yeah, prolasis to the other side.
Yeah.
All right. So while Rahul is trying to cross this, why don't we go to the presentation, and our fellows got some data to share with you guys. So please keep Dr. Patel live on the
let's just
screen as
switch
well,
from-
so they
yeah.
can watch the cross and go to the slides. If you can do both. If you can't, just go to the slides, and we'll save the important stuff. Yeah, you can do
Put
it
it on the
half-half.
side. Yeah.
You can do half-half, or you can make Dr. Patel smaller on the upper corner or something.
Yeah, thanks.
Let me.
That's perfect. That's perfect. Go ahead. You can just bring Dr. Patel's catheter over, maybe to the center of the screen, to the center of the wire. Is my point. You can't do it.
I can move the patient.
Yeah,
So-
we'll just move the patient a little bit. All right, go ahead.
All right, so we'll talk.
There you go. Thank you.
Talk a little bit about iliocaval reconstruction and some treatment options.
yeah, thanks.
So before we get there, so iliocaval thrombosis, it's a major source of morbidity for patients with venous thromboembolism, affecting between 300,000 and 900,000 people each year in the U.S. And you can kind of see on the right, where that is affecting. You can see the IVC there and then the iliacs. So endovascular reconstruction is technically feasible procedure, providing long-lasting therapy, symptom relief in combination with antithrombotic therapy. That's an important part, is make sure the patients are on appropriate medical therapy. And then we kind of discussed this as far as indications, but some indications include severe post-thrombotic syndrome, symptoms of pelvic venous reflux and obstruction,
Overtension.
recurrent DVT, and as important as any of those, or if not more so, is limitations in activities of daily living. So some of the treatment options. So there haven't really been any approved venous stents indicated to treat iliocaval disease. As a result, there are other stenting techniques we use. The most common one is double barrel stenting, which you can see on the side there. Dr. Patel and Dr. Krishna and Dr. Kapoor kind of discussed already. But typically prior to this stent that we're going to use today, double barrel stenting was performed. Other techniques, include inverted Y fenestration or skip stenting. So the stent that we're going to use today, we'll discuss a little bit now. It's called the Viabon Fortegra venous stent. There were 2 trials, one of which has completed enrollment, which is the one for iliocaval disease. The other one for iliofemoral study is underway. So as far as the one for the iliocaval treatment of symptomatic IVC obstruction with or without combined iliofemoral obstruction, so they ultimately enrolled 89 patients. And some of the baseline demographics, so you can see the median age of 50. I think an important thing to highlight is, we try optimal medical therapy on these patients. So the majority of patients, were treated greater than 90 days out from the onset of their disease.
What's going on?
And so patients presented with at least one limb having a CAP classification of C3 or greater, or an RVC-SS pain score of greater than 2, which is the venous clinical severity scale. Goes from 0 to 3, 0 being no real symptoms, 3 being very severe. The majority of patients experienced chronic venous disease symptoms. All were treated for thrombotic disease. And the most common thrombophilic risk factors were varicose veins and superficial venous thrombotic disease. So just some procedural details and lesion characteristics. So in this study, there was a large portion of patients where the device did cross the inguinal ligament. And the majority of patients, 83 out of the 89, had basically stenting in the IVC and the bilateral iliofemoral. And the total stent length on average was about 41 centimeters. So I think this is I think visuals are great for people. So on the far left, you have what the baseline iliocaval looks like in a patient. Then you have the double barrel stenting with a Medtronic Abre, double barrel with a Gore, and the Fortegra stent that we're going to use on the far right. And this is just a nice little illustration of what the fluid dynamics look like. And you can see on the far left is what the baseline looks like with no stents, and on the far right is the Gore Fortegra, which, as we had discussed, kind of you get the oval shaped D when you do double barrel stenting. But with this stent, you basically are replicating as close as you can to the basic hemodynamics of the patient as far as the axial velocity across there. So like anything else, we always want to make sure it's safe and it's effective. And you can see here that the composite primary endpoint was significant in about 75%. And at the very bottom there, you see that there really was no loss of primary patency at 12 months of follow-up and no stent embolization. As far as primary patency, you see that on the left is about 83%. On the right, you see freedom from clinically driven revascularization. And in the IVC, the patency was about 97%, and in the iliofemoral segments, it was about 87% when you break it down by those two. And then as far as a hypothesis-driven secondary endpoint, you can see, we do these for patients to feel better. And you can see that there was a pretty significant difference in their RV-CSS pain score of about 1.4. And equally as important, those patients, the 13 that didn't truly have any issues, no one felt worse after the procedure. So we're not causing this, patients weren't caused any harm by doing this. So as far as the stent, so that's what the stent kind of looks like on the right. It's a nitinol. It has a ePTFE polymer lattice, which kind of helps with the radial strength. So it's an open structure, self-expanding nitinol wire frame, high flexibility, which enables the conformability to the natural anatomy with great radial strength, and that's where the PTFE comes in. Has uniform compression resistance to keep the stent open and withstand any external compression forces. And as we'll show the stent, when we're deploying it, has precise deployment capability supported by the delivery system. And you can see radio opaque markers that kind of give you an idea of where you are in the body. So this is the stent. The system, depending on the length of the stent, it goes from 10 to 28 millimeters as far as stent goes. So depending on the size of the stent, you'll either need anywhere from a 10 French to a 14 French system. And we'll show the stent as well. So as far as conclusion, so this is the first prospective multi-center adjudicated study examining the use of venous stent placement for treatment of symptomatic iliocaval venous obstruction. Some patients did have combined disease, including May-Thurner syndrome, but they were all treated for thrombotic disease. 94% of patients had lesions spanning the 3 vessel regions, which is what we showed. So it included the IVC and then, both iliacs. And the confluence design, which we had shown in a prior diagram, demonstrates superior preservation of physiological flow compared to when you're doing the double barrel stenting.
Beautiful.
And their goal initially was freedom from composite primary endpoint 58%, which was exceeded, as you can see, which was they exceeded it by being at 75% roughly.
Nice job. Thank you, guys. So Rahul, maybe you can update us a little bit.
Yeah.
Oh, go ahead, Srini.
I was going to say just a couple of things. The Gore stent actually has a pre-market indication for IVC occlusion with or without iliofemoral disease. And the other two have FDA indications really for iliofemoral disease. So these are the kind of the first batch of venous stents that have true venous indications. And if you look at all the data and the studies, they basically was a combination of thrombotic and non-thrombotics. But their overall primary patency rate and outcomes and so forth are relatively comparable over 1 to 3 years. And really their differences are based more on lesion morphology and etiology rather than stent design. So you can
Got it.
technically use all of these stents in all these different
So
systems.
it's going with the wire, right?
Yeah.
Perfect. Rahul, what have you done so far?
So, we're having a little trouble getting the left side to go up. So I don't know if you guys saw, but
I can't hear anything.
at one point we were in the wrong area. This is getting strapped again.
can't hear
And then
I don't hear anything.
Me neither.
we pulled back and just tried to find the right lumen. So, if the wire's not going in the right
cut off
spot,
for
just
all
don't
of us.
keep pushing it. Like, just try a different area and see if it goes into the right spot. So here, it wasn't going, and it looked like it was kind of going sideways. So we decided to just balloon the other side to help with lumen passage on this side. So
And how did you size the balloon, Rahul?
we just did 8.
Just 8, arbitrary 8.
Arbitrary 8, yeah. We can go up to 14, but here, like, we're not quite popping in. So maybe if we come.
Is this when you may come from above or not yet?
Not yet. I just see. We may just even balloon it bigger into 14, which is what we have next, just to get a bigger. Because we're clearly in the right spot. We just kind of have to tear into the same lumen, right? So let's come back.
Across the septum, yeah.
And I think you were crossing into the contralateral iliac, right, Rahul, down at that L-fibertival body?
It looked
Was
like it
crossing
was.
over already. Yeah.
It looked like it was trying to, yeah. But now it doesn't want to do that anymore, right?
When you needed to. That's fine.
Yeah, we've done. Sorry, what?
Would you try to come from above to try to rechannel, into that left?
Yeah, that's the next option,
Plan,
right?
yeah.
To come from above to rechannel the left
So,
side.
so there's no such thing as wire escalation, going to maybe a more penetration wire to go break that septum, because we already ballooned, right? So would this be the time where you would do that, or you think, no, at this stage, just wait and just try from above and it should pop through?
We can probably try from above and see if it'll pop through.
Got it.
Yeah.
It's
Got it.
interesting, PK. It's a very arterial type algorithm that
That's
really
okay.
hasn't been kind of evaluated or studied on the venous side. Guide wire escalation. I mean, most people like Kumar and others are saying really stick with 035 glides, and that's kind of their go-to wire for most of the case. And then they're trying the different access points to recanalize because of the etiology of this fibrosis. Sometimes there's no vein there. There'll be like an empty space. And so, but the thought of CTO wires, I think, makes good sense, with what you're bringing up.
Well, it's just to me, it's like, okay,
Pushing on the wire.
what is it? We have a CT, obviously we understand the morphology of the lesion, but the point is, since we know there's a septum, we know we're in the right spot, do we pop in with a wire? That's just my question. I mean, obviously I do not do this work. I mean, we do what is it called? No IVC work. So I think these are the cases where Rahul's expertise is incredible, and we learned so much from him. But that's why I was asking, because from our algorithm, the next step would be, as you guys know, for the arterial side, is to just go up with a different wire. But I mean, clearly here, there's a lot of logic to what you're doing.
Yeah.
Is any difference between soft glide and stiff glide? I mean, does that matter or no? Because you don't want to loop, right, Rahul? You definitely don't want to loop here.
Yeah, I mean,
He's avoiding.
I'm trying to avoid looping, just because it just creates. If you're not in the right spot, if you're very sure you're in the right spot, then it works. But if you're not sure you're in the right spot, then it becomes messy. I think we're in the right spot
just
now.
spiraling around it, which is
The technique here, I can see what you're doing here. Your wire is moving very freely. Does that have the same implications, Kumar, when the wire moves that freely like we do in the arterial space, or it's different here because it's such a large vessel?
It's a little
You're breaking up, brother.
pretty freely in the venous system. If it's kind of still maintaining its front end, that's fine.
Got it.
I think also, PK, in the venous system, oftentimes you don't really have like a tube that you're trying to get into. It's like a thin thread. And so I think that's the reason why, like Rahul said, he's avoiding that the buckling or the looping of the wire, because if he's in the wrong path, then he creates a really false channel, and that makes the rest of your recanalization, as you know, very.
Got it.
Everybody.
The other thing with Rahul's approach is nice is that without shoving the catheter up too far up, you're not creating too much of a wrong plane that you can't get out of. Because in the veins, it's less forgiving compared to the arteries to find a new path and stay in the lumen.
Yeah, for sure.
So I'm gonna be a total how can you say zero knowledge to ask this question because I know people are thinking it outside. Any role of re-entry devices? Your Outback, your maybe you do a what is it called, facilitated re-entry like we do by putting a balloon up in the other side and then ballooning and then capturing the wire and pulling it up. Is there any such role in the venous system? And have you guys done that?
Definitely, yeah.
So,
I mean, definitely
yeah,
done that. We've been doing
yeah.
we're definitely doing a lot of different techniques. We use a lot of RF wire, bayless wire, snares with. I mean, re-entry devices such as Outback, BBAC have been a little bit less on the venous side. Usually,
Okay.
one of the other slower profile things can also work well. But what Rahul's doing is exactly what we try to do. It's just that you don't have as many layers. It's not like you're in the subminimal plane of an artery to
Right.
pop back in. It's a little different. You're outside the wall usually, if anything else.
Got it.
Yeah, I'm not 100%
Good to know.
sure.
Yeah, that's a
Yeah,
great
yeah, no
point.
prolapse.
You're either intraluminal or you're completely out. There's no in between. That's definitely
Yeah,
true.
No in between.
Yeah, so here I think we're just out, right? Like,
Yeah.
because we got up to that spot and it just didn't go. So why don't we do this? Why don't we balloon this side bigger and see if we can tear into it, right? I got the sheath. Can we get one of those 6 or 14 millimeter Athletis Gold?
14 millimeter balloon, guys.
So we ballooned to 8. You know,
The
it's
other
probably
option is
not.
the other option is putting in a snare from that right-sided sheath right at the confluence and kind of targeting that.
Yeah, poking through. Yeah.
Yeah.
You love snares, Kumar. I know you've done it in the
I do love snares.
arterial
I do love
arterial
snares.
space. Yeah. You love those micro snares and all that stuff, you know.
Well,
This
here,
one you
I
can
mean,
put a big one on the right. You can put a big
can
one
put
on
a
the
big
right. Yeah. Yeah.
Well, no micro here. I agree.
Yeah.
But
Yeah.
it's funny to me
Plus,
that
we have
You're-
the best job. We get to watch Rahul and everybody work. And
Exactly.
we can say what you should do.
well, remember, they see, I'm very smart. That's why I brought Rahul in because this is great for me to watch. It's awesome, and learn. So this is great because as a cardiologist, you look at this 14 millimeter balloon in an occluded vein, and you're like, oh my God, But I mean, that's understanding the CT, understanding the sizing, right,
this is
and then
probably
deciding. So Rahul, you're
40.
trying to break the septum between the two here.
Yeah, just to create a bigger channel, right? So 8's probably. Man, this 14 looks huge.
I'm
but
at 4.
yeah, just probably take it to like 6 or 10.
Yeah, hold on. Give me another inflator. I don't have
So
anything.
she's definitely feeling that.
Yeah.
So she definitely felt that balloon, obviously. So
Hold on.
So we've got her monitored hemodynamically here, Kumar. I think we lost
Yeah.
Srini for a second, and so
Yeah.
is it the same things you look for? Pain, hypotension, God forbid, if anything is
10.
going on here, or you expect pain here?
Yeah.
Down.
For these, you typically won't run into hypotension. We also lost the video feed, PK, but we don't usually run into hypotension. We run into pain as
The
the
video,
biggest
they
threat
can't
to
see the
septum
video,
problem.
guys.
Yeah.
And we lost Dr. Tumala as well. But I'll just tell you what, just
I'm
describe
here.
what we're
I'm
doing
here.
here. Oh,
I'm
you're there.
here,
Okay.
But, yeah, we
You
just
lost the video
feed, and Kumar is in big form right now. I see him on
Yeah,
the whole
Kumar
screen.
takes over the whole screen.
Always.
8.
Well, this is
Just
my
like
time
real
to
life.
shine. No, I'm kidding. Just kidding. No, but PK, to your
Wow.
point, I think pain is the biggest thing you want to be aware of, and that's why it's nice if you can do this without the patient completely out, because that is a good indicator. I mean, even when we do SFA work, that when people feel pain in the leg, you got to be careful what you're doing. So same thing here. Pain's the first sign of you got to be a little bit less aggressive at that point.
Yeah, to me that's why here
10,
the idea
12.
that I was asking is the ballooning, and I guess this is where IVUS might have played a role because when the wire goes up, I mean, can you be certain that you're truly in the true lumen even if you're up in the atrium with the left side here, and so that's why whether IVUS helps or not. But I guess if you're through and through, it should be okay. And you're saying even if you have a little pee, it should not be a big deal, right? Because it's occluded.
Yeah, it's all occluded.
It's all occluded. Got
Yeah,
it.
so they're not going to bleed from this, right? They may have a little bit of pain. Actually, we can hold off for now.
Yeah, sure.
Let's just.
Kumar, Srini, can you see the video feed now?
Yeah, I can.
I think you can see it. Okay, great.
There we
Thanks.
We'll probably just
Yeah.
pop over to the
So,
other side.
so we ballooned with the 14. Just an update as Rahul keeps working here because this is really a tough case. And you can see here that now he's trying to re-enter a little bit below near the confluence. So, are you trying to get into the other side, Rahul?
Yeah, if I can get to the other side, then I can just flip it, right?
That's awesome.
Yeah.
That's a great technique.
Which I think I'm going to be able to do. Actually, can we back up a bunch?
Yeah.
Just so everyone can see at home.
Yeah, so this is what what I was thinking originally is that it seemed like your wire wanted to go to this side, and hopefully if you can cross over and flip up, that'll be a game changer. Hopefully.
Is that hard to do, Srini? Flip it up because with such a small lumen, in the fibrosis.
I mean, usually with the tip of the guide wire, you should be
Yeah,
able to
that's a
do
better path.
something, like a
Got it.
loop like this, and then
Give me a new stiff angle glide wire short. We've just
And
probably
Kumar, you
gone.
were talking about a special catheter, like a
180.
laser catheter. What were you saying about that?
No,
the
for a
other-
lot for a lot of
this
chronic
wire's
Yeah,
occlusions,
sorry,
even
trashed.
arterial venous, we're using a lot of RF radio
Yeah.
frequency Baylis wired recanalization, where basically it'll go through anything. You just have to make sure that you're targeting it very well on multiple planes, but it'll slice through anything. So if you have a good target, we do it for a lot of central recans and even some of the arterial stuff. We looked at it. I think using some kind of low profile system to kind of target things first, especially on the venous side, is very important to be safe.
Got it. So Rahul, from a layman's perspective, watching here, so I see that you crossed on one side, you do that balloon escalation technique, right?
Yeah.
And you're still
There.
on the ipsilateral side. From below. So would the next step will be from above, or would you go with
That's
the Baylis RF?
I would try from above, right, to
Above.
see.
So the algorithm would be the next one.
Yeah.
Got it.
Well, this isn't running to even go down the other side either.
Yeah. No, it's
It's
tough.
just next to it.
It's trying to. It just doesn't want to poke through.
Can you guys hear me? Do you think you're next to your wire and sheath on that right side with that wire, Rahul?
Yeah, you can see it like as I'm pushing the wire, like it's moving the other wire, right? Like it's.
I know.
moving the other
I know.
side.
PK's gonna make fun of me, but if you what
Want me
we've
to
done
walk
in
my
these is
balloon out? Maybe give you more.
we actually snare that wire and we push the sheath with the wire straight up, so it rails it together up into that same plane.
Yeah.
Yeah, I know. I was waiting for you to go on about the snares. I think you have
I'm
stock
telling
in
you,
all the
man.
snare companies.
I wish I did. I wish I had those kind of connections. I don't have a consortium.
Oh my God, that's funny.
No, but
this is-
it
I mean,
saved us a couple times on that. Yeah.
No, this demonstrates the difficulty. I mean, one side is done, but you're still not done. I mean, it's a lot of work to try to get through this. And Rahul, is this left side harder because of the
What I'm going to do is
matrix
walk
that
my
you
balloon
have?
Yeah,
back a little
it's
bit, give you a
usually-
little bit of lumen.
Okay,
Yeah, let's see if we
So
can
that
go
way
look.
at least
that's good to know.
gives you a little bit more.
Yeah, but it's still not wanting
Yeah,
to go.
still
Like
don't want
it's.
to go. See,
Let's see. I mean,
yeah, maybe just
So it's interesting to me that how you
Let me give you a
resist the
catheter
temptation
support
of
from
taking
front,
the
so
loop,
that
which
way.
is great.
yeah,
Really
it's
watching
not really in
really
lumen.
be careful with that.
All right.
Yeah.
Let's see. We can try from above, or we can try with the snare.
You want a snare? What size would you guys? What size would you take, Kumar, snare wise?
10 snare, or it depends if you have a tri-lobe or a gooseneck. A tri-lobe's kind of nice because one of the pedals may grab it, but 10 gooseneck's also fine.
Yep, we got a gooseneck 10 in front of us. I'm going to just pop it open in case Rahul wants it. Just pop it. It's okay.
1 second. He's
So we're gonna
almost.
As
have
soon as you
ready
open it,
here.
you won't need it. As soon as you open it, you
Yeah,
won't need
see,
it. Don't
I'm
worry.
gonna.
Well, let's see. Listen, that's part of the trick, right?
Making Rahul work under pressure.
I know you always say it's the snare, but I know it always goes through when you open the snare. All right.
Yeah, I think it's.
So as far as
just right there.
anticoagulation, Rahul, is it always heparin when you do these cases?
Yeah.
And what ACT are you aiming for?
We just want them. Yeah, it's not in. It's just the same.
Yeah, just same track.
Yeah. We want basically about 250, right? Because we don't want them to form.
You want the snare?
Yeah. Let's do
Okay.
the snare.
So here's the gooseneck. So I flushed this catheter.
I mean, the good thing is Rahul, has crossed from one side, so he can ultimately, put a catheter over
Yeah.
this wire and come down as well.
Yeah,
And
they can come
then
from the other
at least you know your then you know your
Exactly.
intraluminal, and then maybe at that point try from above and below. That's another option, as he knows.
Yeah. Yeah.
So what are you saying, Shane?
Actually,
for us,
to lose
running a
the-
parallel
come
to
from
the wire.
above
Put it
with
straight up, huh?
with
We're
another
running a parallel.
catheter, and then
Well,
and
there's
Yeah, no.
Give that glide
We're
wire.
going next to it. Can I have another glide wire?
There's
Another
two
glide wire?
ways. There's two ways I'm thinking
Yeah, we
about
don't wanna
this at
lose
this point, since
track.
it's so different. One is the
Give me another
snare
glide wire.
technique that Kumar talks about from below. The other option is you take the catheter that you have from above and try to recanalize from above into that iliac vein. And then the third option is
flush
to
it.
put a catheter
Flush.
over the existing wire. You have to
But you don't lose.
externalize it from above first, put a wire through it, and then put your catheter all the way down to where you think the confluence is, and then try to recanalize that way. So that's
you're not
another
worried,
option too.
You guys have just put one question. I know people are thinking this. You're not worried about losing the wire access. God forbid if you have to lose the wire.
No,
so
I would put a
Yeah,
I would put a
okay.
catheter that's big enough to keep the existing
like a-
wire as your rail, and then try to recanalize with a second wire through that.
Got it. So
Yeah.
you're
Does that make
okay.
sense?
Okay.
To Srini's point, that's a great idea. The other thing we do with that
Yeah.
same approach is we just put a large sheet down that one wire. You can put a second catheter through that while you still maintain that access.
That's a great point because I think
Yeah.
that's good for everybody
Yeah.
at
That's
home.
what we did. We put
Because you don't want to lose the wire access because you might
Correct.
have ballooned
Correct.
it, but then you might never be able to get back in.
yeah. So
that's
that
very
Never lose
interesting.
wire
so
access.
that's what we did. We put another wire next to it, so we don't lose
Okay.
access, and then we're snaring it through it. Yeah.
Yeah. Let's see.
Sweet. This will tell you if
So
you're in the
let's-
same area anyway. So
Yeah. Nah, we're not in the same spot.
Maybe some obliques, huh? See where
That's
you
right
are,
there.
I guess.
Yeah. Let's see. Yep.
Yep. That's
this
exactly
is where
what
this is
Rahul-
where PK is feeding for some reentry device usage, I think.
Yeah,
Right.
well, I mean, you put the Outback in or
Let's see,
the
that looks like
Pioneer
works
in,
for
and
you.
you
Yeah,
plug
looks
right
right,
in.
yeah.
I'm joking, guys. I haven't done this, so I have no
Yeah.
idea. So I'm
Looks like
just,
it's through.
Right
I'm
on
just
top
giving
of
you
it.
thoughts that come out of my, my interventional
Yeah.
brain and see what we would do. But obviously, it's important for especially everybody watching who doesn't do a lot of venous work. It's very different than arterial work, and there's a different principles, and that's where we're trying to teach this. Is the different principles that
we're
are
not
guiding
through.
our recanalization.
The other thing, you can go bombs away and just take the back end of the wire, but here it's not going to go sideways, right? It's going to go
Straight.
straight up.
Yeah.
Yeah. Easier to do on the right side. I think we're in the different
No.
lumen.
Yeah, different lumen. You don't
All
feel
right,
it.
so let's try from above.
All right. So which catheter would you need from above? You need a.
Nope, we're going to take that MPA that we have.
Okay. So multi-purpose. We're going to come from above.
And then do we have another glide wire?
Another
Yeah,
glide
well.
wire, guys, and a
PK,
multi-purpose
to your
from above.
point, we were asking PK about lower de-escalation of wire size. Some people do that with like the triaxial Cook system, where they go down to 018, 014. So you can do that through tough occlusions as you progressively go. But in this kind of IVC territory, often that bigger
Right.
wire is needed. Yeah.
Can they see a little higher?
Yeah. So I'm just going to move the radiation shield here because Rahul has I guess an assistant monitor over there.
That's good.
And-
Oop, not so high.
And
I'm sorry.
Oh, too
What did
far.
I do?
Yeah.
Too
Keep
far
going
out?
down. Keep going down.
No, we're not
Do
too
it
far
on
out.
floor so you can see the.
I already have the
There you
MPA.
go.
Whoop, other way.
Ah,
Down, down, down.
There you go.
Nope, keep coming.
A
Keep
little
going.
Lower,
keep going
lower,
up.
lower,
Lower, lower, lower, lower, lower.
lower, lower.
There you go.
ah, perfect.
Good.
Yeah, let's see.
So what's the target you're using here? Just following the wire, Rahul?
Yeah, I'm following the wire. I mean,
Okay.
luckily we've already ballooned it to 14, so it's kind of just going.
Right.
And then I kind of like the MPA for this because you can kind of.
So would a snare from the other side help for you as a target now to put it on the other side?
Maybe. Let's see if I can get it. Do you have the glide wire?
Yep. Glide wire, guys.
Yeah, I'll give you the pedal rope.
Yeah.
Yeah,
go,
pass
Rahul.
him the. Mikey, pass him.
So Kumar, in this stage, you'd probably put the snare from the other side. I'm assuming.
Can you
right?
give me the pedal wire?
I mean, I would see sometimes
perfect.
just like an artery, sometimes just
Yeah.
going from above, you might find
Well, you have it.
some kind of a channel that you created from below, or if that doesn't work, then I try considering targeting with the snare and some kind of either facilitate entry or just the back, some wire escalation into a snare type of thing. But I mean, the wire may just go into that left side. If not, then I switch the snare.
Thanks. Oh.
Right.
Give him a torque. Let me get.
You can never have enough
interesting-
snares, PK.
I'm just gonna try from the bottom.
Yeah, of
in the
course.
meantime.
Oh, two sides we're trying here.
And dueling.
Dual.
Just have some kind of weird affinity towards each other from
Yeah.
some engineering study, so you never know.
Yeah. There it is. Nope, not quite.
We feel you, Raul.
Yeah, this is tough, man.
Yeah.
Oh, I
These are
mean,
tough
listen,
ones.
doing live cases. I mean, my God, it's so difficult, and
Well,
it's obviously so.
The part that hurts the most is the right side goes so smoothly. That's always
Well,
the
actually,
part.
Rahul predicted that when we were here.
Oh,
He
did
said,
he?
the
Yeah.
right's probably going to go easy, and it's interesting that the left, it's the May Turner. I think the fibrosis that he's dealing with is so bad
Yeah.
that it's
Yeah.
just not able to go.
Yeah, this isn't working either. Do we have that 565 Berenstein?
Berenstein?
Yeah.
Berenstein, please.
The MPAs.
Yep,
not-
it's
not
right here.
being-
Berenstein's right here. Is it long enough, this one? Yeah, okay.
Usually the MPA.
Is this long enough, Rahul, for you?
Yeah.
Okay.
Rahul, do you feel
Flush
any
it.
value in on the left side coming back down and try to find another little channel to come up
Yeah.
that external?
Yeah,
common?
yeah, exactly. That's sort of the next thing. Although it looks, it's
It
Looks
does
like
look good,
right
though,
up there.
yeah,
Yeah.
it looks so
Yeah.
close. So
So Kumar, talk and Srini also about this external beam CT. Obviously, we don't have it here. How would that be of use here for people who are doing a lot of this work?
So for me, it helps
Where
because
is
if
this?
I see
Is
my
this a 6
catheter
or a
and guide
5?
wire going a
Huh?
certain direction, and I'm
Oh,
not
it's a 6
sure
French.
if I'm near
Bernstein.
the target entry point, the cone beam CT
Didn't know you
shows me
guys had
because I
6
can
French
see the anatomy. I can see, am
So,
I outside? Did I perf through the iliac vein and I'm just in the
Oh, sorry.
retroperitoneum
No, it's
and the
fine.
fat, or am I still within the vein itself? And then it gives me some directionality of where I am relative to the origin of that iliac vein. So it just gives me directionality in my case.
the other thing, PK, when you do these complex iliac completely occluded systems, sometimes you don't realize you're actually real close to the artery or even the ureter. So
right.
sometimes if you're in a concerning area or you're not sure, it's always great to confirm with just the wire placement to know where you are.
Got it. Got it. That's a great point because you have all these structures right next to one another. You're absolutely
Yeah.
right about that. Okay, here's the Bernstein. The other question I wanted to ask you is
This is fine.
role of ultrasound. I know in arterial work we sometimes put external ultrasound to look. I mean, would that be useful or this is just too difficult? Rahul, have you done that with ultrasound?
Nah, for like transabdominal ultrasound.
Yeah.
Yeah, that's tough because a lot of these patients are a little
A little bigger.
Yeah,
Okay.
it's hard to see to that spot, and then you're not even
If
seeing
you
a
look at
lumen.
if you look at the regular ultrasounds you order for anything in the IVC area, it's not the greatest for much as it is. So just not
And
penetration
I
power
think
enough.
it gets back to PK what we were talking about. A lot of these veins, when they're chronically occluded like this, you've got negative remodeling, and so you have really just a fibrotic strand that you can barely see on CT, and you don't have an actual tube, like a chronically occluded tube like you would see in an artery, and so and visualization would be really impossible.
Wow. Okay. I'm just gonna pull this back for you guys. So, Laura.
Yeah. Yeah, you can pull the.
I'm just going to pull that out of the way a little bit so these guys can see a little bit better. So you can see for those at home, I mean, go ahead.
No, I was going to say you can see the challenges with this type of revascularization. The other thing too is you can see the Achilles heel of this reconstruction is really going to be that confluence, right? That's where
Right.
you get kind of the most challenge in terms of getting optimal luminal gain, is where those iliac veins join the IVC, and that's where you have to really optimize your lumen at the end of the case.
Yeah, it's just.
Got it. Got it.
It's a little different channel, but.
Let's see.
The challenges of these cases are amazing.
Yeah, I mean, also trying to figure out, like, you're guessing, right, where the.
Mm-hmm. Oh, you're touching, aren't you there?
I thought so.
Oh, I thought you were. I was Vishal is moving.
Yeah.
Are you Vishal
It
pushing?
looks awfully close.
Yeah,
Though.
it's like right up there.
Oh, no, that's me.
Yeah, to Srini's point, with possibly like the Maytherner there, your planes are going to be very difficult to
Yeah.
figure out where to get to.
All right, I'm gonna do this.
And you can try to outback. You could try to outback into a balloon, right, to get across. 'Cause
Yeah,
we're
that's
so
what I was
close.
asking.
Yeah, we've done that.
You want me to get
I
a
mean, you have a big,
Pioneer?
you have a
I
big snare.
have
You have a
Pioneer.
big snare there. So,
Yeah.
I also have a
You can-
Pioneer,
you can-
guys. So
yeah.
we can do a Pioneer to show the flow in the vein or whatever it is, or if you want the outback, we have that as well.
Whatever works. I haven't used a Pioneer in a long time.
So this is interesting. So I think for those at home, the escalation technique in this particular case is obviously balloon, try to create break the septum, use the wire from below and go up, and then obviously come from above, try the snare,
Yeah, I think from
And
above
then-
ain't going anywhere.
and then eventually
Yeah.
the balloon.
Yeah.
So would you like the outback or the Pioneer, Rahul?
Whatever. I haven't used the Pioneer.
I have both.
Yeah, whatever works best for you guys. I don't.
No, honestly, we have both. So
Yeah.
whatever you prefer.
Yeah, we can use.
So what do you think? Will we do the Pioneer?
You could do the B back here too, which since you have a bigger adjustable throw.
Yeah.
Whatever you want. I think the Pioneer has the longest throw, right? Even more than the B-back.
Yeah.
So the Pioneer, I think, has a
B-back's
5.
30. What is it? 33. 3.3.
I don't think we need a long. I don't think we need a long
I don't
throw.
think
They're
so
pretty
either.
close.
So what would you like? We got both.
whatever you want. I don't.
All right. I guess for those at home will use the Pioneer, or what do you recommend, Srini and Kumar? Pioneer or Outback? Either.
Either is fine. I mean, I don't know if the IVUS part can help you maybe here. We don't really use it for
So
this
if it
kind of
doesn't help,
situation, but
well,
maybe
let's
it'll
use
show you.
Outback
Maybe it'll
then.
show you target.
Yeah.
Yeah, either way
Let's
is
use
fine.
Outback then. Yeah, we'll go with the Outback because if you're saying
Nope.
IVUS is not going to be
Yeah,
useful, we'll just use the Outback.
I think
Oh, it's a 6.
So
right? Actually, it should
I
work,
know,
right?
I know
Yeah.
that
It's good. Yeah.
a lot of the
Pioneer goes for a
newer
6.
generation
probably
cardiologists and
goes-
radiologists and vascular surgeons don't use this re-entry devices as much because of pedal access and stuff like that. Yep.
Yeah.
Back when we were
Gotta get ourselves
growing
close,
up,
right?
Yeah.
this was sort of like
That's
the
what I'm
go-to
saying. It's just-
as we were learning different techniques of crossing. So this is actually
like
a cool
that the
case to
best.
see in the vein.
Yeah.
Let me see here.
Where's that going?
Yeah, it's not going anywhere good.
There you go.
Yeah.
Mike, can I have a flush? You can grab that. Let me just throw this on the ground. So the key with the Outback is, guys, you got to flush both the ports, both open and closed. So I'm going to flush now.
All right.
Okay, and Vishal rip
I
the
think
rubber off.
we also have to be careful here, just because obviously you're going to have the iliac artery right along that vein there, and we don't really know where it is because we're working with two dimensions. So something to be cognizant of.
So
first, you have to exchange for an.
So I flushed the Outback.
You have a
We need
Spartacore
a
or
Spartacore wire, please. So all these systems go on
what
an
do you
open 4 wire.
this may not. Well, let's see. It may go, may not, because it's a tight lumen. We haven't ballooned.
yeah.
Oh, you're just going to go without it?
No. We need the wire, but I'm saying it may not go because we don't have a lumen to go through, right?
Spartacore is good for you?
Yeah.
So we're using a nice support wire. Can I wire introducer, guys, for
It
Dr.
is
Patel?
really close.
I know, man.
There you go. All right, and then I'll backload this.
Yeah, thanks.
So Srini, I think then I think the Pioneer would be helpful if you're not as facile with this,
Right there.
knowing where the iliac artery is and so on and so forth. I think a Pioneer would definitely show you the artery, right? So you'll be able to see that with the Pioneer and the aorta as well, So that's a very good point, Srini.
Just because there's a lot of things crossing there, and that's where cone beam CT helps too, because we could see, are we actually within a lumen, or are we just in the adjacent fat trying to get a connection that's not going to happen,
Yeah. Well, look, like I said, most people don't have the luxury of cone beam CT, so I think this is a nice way, and we have the Pioneer ready. If the Outback doesn't, we don't feel comfortable, we'll switch to the Pioneer. So, I think this is just showing different techniques. You got
Tough
the wire
case.
distal?
Yeah, he has.
You got it, brother,
Yeah.
over there? Okay,
Yeah,
good.
I got it.
I'll pull it to you. Good. All right, so here we go. All right, I got your rail here.
Let's see if this goes. It may not want to go.
Can you pre-balloon that side?
Yeah,
I can't remember
that's
if
what
you
I
pre-balloon that side.
Yeah. I'm gonna push the wire back up. It's not gonna go. We need to pre-dial it. Do you have like a 016 or 018 balloon or 014
Yeah.
balloon?
What size do you need?
6.
6.
6.0, like 80 balloon.
Let me try
Give
from
us
the top.
an 018 balloon. You got it? Just pull it off here.
Where it got stuck
like
is
mine?
probably where your biggest problem, where the wire goes at different angles.
Let
is
me
probably
floor-
exactly
let me
where the
try.
6.0,
problem
any
is.
size, man. Whatever you got.
6, 8. Whatever.
So we're gonna go right. Flush. Right. So Kumar, Srini, I know it's an hour. If you guys got to go, don't worry about it. We're gonna record this to the end and show everybody. If you can stay, of course, it'd be wonderful. I know you guys have cases, so it's up to you on what you can do.
This is a great case. I'd love to stay on for a little bit more. Yeah.
Yeah,
Yeah,
please.
me
No.
too.
I just want to be respectful of your time. Rahul
Yeah,
had
thank
actually
you.
told me that this may take a little bit longer, but I'm just saying that as far as we've done cases like this, an hour and a half, whatever it is, to get it done. But I think for teaching perspective, this is a great case.
Absolutely. Absolutely.
So I'm going to just balloon it. And what you want me to go slowly, fast?
It doesn't matter. We're just tearing open the space here.
Just want to make sure.
Also, once you do that ballooning, you might have just created a nice channel from above.
Yeah,
Where
exactly.
The Outback may not be as needed. I forgot you had a balloon that side.
Yeah.
Well, clearly there's the web.
Yeah.
Okay, there you go. Nice. Okay, this
you
is
might
at
get
8
into this at
atmospheres.
this point.
Yeah.
From
Let's see.
above.
God willing, that'd be great. Okay.
Get that wire from above, start playing there.
I got it. Looks like the wire's pointing right there.
Just balloon there again. I don't think there's any lumen
Balloon
there.
again?
Yeah, just to.
Just gonna expand this here. Good. Boom. Right there. Beautiful.
Is the short one?
Just gonna walk this out now.
Yeah.
Okay.
Okay.
I'm going to change it for a short word tip from the top.
Sure. Yeah.
I just want a little bit more angle to it.
It's coming.
Oh, Mikey, come. Hold the wire.
Over 3 more thousand.
I'm going to walk this out. Keep the wire there. I'm going to walk the catheter out.
Go forward a little bit. Interesting. Try again.
Watch.
There you go.
Walk the catheter. I'm going to hold the sheet.
Got wire.
Keep
And
the
now I'm
wire.
gonna reload. Yep.
Perfect.
I'm gonna
Keep the
reload
wire there.
outback.
Fine. Keep the wire there.
Got wire right.
Perfect. Keep the wire there. Beautiful.
Okay. Michael, you flush the outback for me.
Yeah, it's flushed.
Good.
Thank
I
you,
got
buddy.
it. Go.
Raul, you're going back in with the outback and then trying also at the same time from above. Is that kind of
Flush
plan right
this.
Yeah. Yeah. Exactly. Just.
Well, Vishal's giving it a go from above while we're getting the outback here going in.
now? Yeah, great idea.
So I'm just gonna pull it to Rahul. I'm pull it to you. Hold the distal wire, Rahul. I'll just pull it to you. There you go.
Got it.
Okay. You can pull
Yeah,
it.
yeah, just pull it to you.
Yeah.
There you go.
Keep the wire. Don't let it
Good.
go.
Beautiful. You can see what a difference that made, you know? So would you like any different wire? You still want to keep the Spartacore?
I think the Spartacore is fine.
Okay, good.
So now we got to figure out which way.
Yep. So now, Vishal, we're going to move the C-arm.
Yeah.
Go
Do
get
whatever
it.
you want to do.
Now, why don't we
You
give
got
him
a
a second?
torque
Let him
needed.
try with the outback. Why don't
Okay.
you give it a second, Vishal?
Okay, I'll pull back.
Yeah, just for a second.
Sure.
So that's the T. So let's make sure the L, right?
So you still do the TL configuration? Wow, fantastic. So everybody at home sees the T?
Oops, sorry.
Careful,
Now the
guys.
L.
So that looks. T. Is that right?
Does that look like an L to you guys?
That looks like an L.
Yeah, I agree.
Yeah, that's
Sorry, I'm
enough.
gonna just go to the other side just to make sure.
Yeah, I agree with you. Well, you know, our Gore rep
Just
was
a little
the
off axis.
star
There's
rep
the
of
T.
Cordis
Yep.
Yeah.
a long time ago. He knows about the T and the L, so we
Yep.
can ask him.
And you
There,
didn't
I'll
want to
get the
snare
pedal
from
right
above,
there.
Rahul.
Try.
You wanted to snare
Perfect.
from below instead. Huh?
I'm actually.
Okay.
We have enough space. I can push it up. You know, like I'm just gonna
Got
drag
it.
it up.
Got it.
Yeah.
So
So,
now,
Makes
so
sense.
the T and the L have been done, and now he's firing.
that's fired. Let's see.
Okay. And this is one of the things I never understood why the needles weren't opaque.
Exactly.
Well, let's see if it snares, right?
Yep,
That's
that'd
really
be great.
You
if
want
it
to keep a
snares.
smaller target with
Yeah.
the snare, maybe. Yeah.
Yeah. This didn't snare.
It's a big snare, yeah, no question.
It looks bigger than
So
a
that's-
10, right? Or is that just magnified?
It's a 10. No, it's a 10. I magged
It
it
is?
up for you
Okay,
for everybody
okay.
at home. Yeah,
Thank
I
you.
just magged it for everybody. I know Srini's getting a little long in the tooth there, so being sensitive to the elderly in the room.
Oh my.
Didn't.
Little elderly, humor. You know how it is, Srini.
That's right. That's right. Don't hate on the
can't-
elderly, please.
TK, I can't
No.
believe you trained under Srini. That's crazy. I can't believe that's how old
Isn't that
he is.
crazy? Isn't that nuts? How old he is?
I can't believe he was your attending.
You know the best thing. It's like Srini's boasting to me about all the senior citizen discounts he's getting. It's unbelievable. It's like
Srini has bad video transmission. He's out.
Srini's suddenly cut out.
With
Yeah.
two little kids at home. What a
Wow,
guy.
some
What a
reason,
guy.
some reason I have to sign off now. Unfortunately.
So Rahul,
It's
as
not
even though
popping.
we're joking here, I mean, in terms of, I know you're working really
Yeah.
hard. You're now different, I guess, planes you're trying to get this into. There you go. That looked good,
Maybe.
Rahul. Can you snare it now? I wonder. That looked good.
No, I think you're in there now. I think you're in the lumen now. I think it's just
Ah.
a chronic occlusion you're dealing with.
Yeah. So then the question is, should we go back with?
The wire
To
now,
a catheter,
right?
maybe?
Wire catheter, yeah.
Yeah.
Because you're actually, I think, right next to that guide wire. You're in the lumen, I think,
It looks,
at least down below.
But then but then it separates again.
But
Yeah.
why shouldn't you be able to snare it then, Srini? That's the question, right?
Sorry, this is just getting a little hard
You
to.
want me to
Well,
walk
we
back?
didn't.
No.
I don't think we went. I don't think we punctured through the snare. That's why, right?
I see.
Yeah. Like it's
Walk it
this.
back, buddy.
Yeah. I think we're gonna have to walk it back.
No, it's totally
Yeah,
two different
it's-
planes.
It's 2 different planes.
Yeah, still.
Yeah.
You want to try with the Pioneer now?
Huh?
You want to use the Pioneer in a balloon or not yet?
Yeah, we could try that.
Yeah, give us a Pioneer and we'll put a balloon in. I think this is where the balloon is going to be a nice target for us to hit. And I really think this is so large that I think the balloon will really help us.
Yeah.
All right, you want to grab that? Yep.
Yep, I got the
All right.
wire.
So again, the Pioneer differs for those who haven't used it from this one because it's an ultrasound-based, catheter. So it uses it's a Philips product, and it has a long throw needle and the and the what is it called, IVUS. So it's the same thing. The setup is the same thing. You have to flush the IVUS, which I'm doing here. So it's very important to make sure that you do this part. Saline right here.
So, I mean, the one other trick is you can
That looks
force
sort of close there. What wire are you using from above there?
just a glide wire.
Still a glide, but you know what? In this case, I'm not
You're
latching onto
hitting
it.
something. Oh, okay.
Yeah.
So now where would you put the balloon up from this side?
I would put it right where that snare. I mean, right where the snare is, in that just above the confluence, spanning the confluence.
You got a wet one?
Going up.
You got a wet one in your hand? Here.
That's rapid exchange.
There you go. Give me another wire, guys, from below, like a command. Command 014. Exchange length. Okay, good. I got it now. So now you got to put up the IVUS here. So there's your Phillips catheter going up. And again, there you go. Beautiful. Beautiful.
You have to be somewhere
Okay.
around there, right?
So we need to go up on IVUS, guys. So this is where I think you need a target, and that's where I'm worried. Can we bring IVUS up here, Dame? Do you know how to do it? I don't know how to. Stop floor, guys, for a second. He's got to change. So you're going to see the IVUS on the screen too, Kumar and Srini, so you'll see that in a second. Let me see. There's his IVUS.
Yep.
Okay, good. All right, fantastic. So I'm going to you can clean this up for us now.
We just need a balloon, right?
Yep. Which balloon do you need?
Whatever. We can use that 8 balloon that we used before.
There's an 8 balloon.
Or what size balloon was that?
There's an 8. Oh, shit.
We
I
need
dropped
that.
it. Need an 8 balloon, guys?
We're going to need that balloon again.
Yeah, we'll give it another one.
Do you have a 14 Atlas Gold?
Yeah, we have a 14 Atlas.
Okay.
14 Atlas balloon. You want that or not yet?
No. Yeah.
If you need
We
it.
just need it later.
Yep.
Yeah.
We got it. All right.
I think Vishal's on a mission. He's gonna pop in before you guys do.
I just need it's not latching onto it. I think I would
Here you go.
scale it down to a smaller caliber, more stiffer
need
wire to go in
14.
because the lumen is so big. See how it just writes up right there?
You
but
might
it
as
won't.
well. You might as well. I mean, there's nothing wrong with it.
That's
You can try any size wire at this point.
Yeah. Can you give me a confianza real quick,
8
please?
balloon.
Give me a long confianza.
So I have a question, guys, here from my end.
Yeah.
In terms of this balloon,
Damien confianza.
you're going to have the snares out now, right?
Yeah.
So the balloon goes in, and then you're going to target the balloon. And are you going to push the balloon up?
Oh,
or
start
are you
with
gonna pull
20.
it
What
down?
are we
I'm going to try and push it up.
Uh-huh.
And then if I can, then I
20.
can just push
Start with
the... Keep pushing up.
Or
and
whatever
hopefully
confianza I have, that's perfect.
Take the... or even just push it or pull it down, actually, once I'm across on the other side.
Go ahead.
And then I can bring the
Okay, I got
4-French glide cath back around, right?
Can you get
I can pull it to you.
Damien? Give me the confianza.
Okay, go ahead.
Yeah, here. Go ahead. Sorry.
So there's the balloon now. Perfect. So we have the balloon. Now you have the IVUS. Now you want to inflate the balloon.
Yep.
I'm going to pull my catheter back. Just to give it a bit of room.
Okay. All right. Nominal is Dame about what, 6, 8? Laura?
I'm going to punch her into the...
There you go. Perfect. That is
Do you guys see the balloon at all? Are you
Confianza.
going to change on the IVUS? I don't.
not yet. You're
I
gonna
don't
you can
see it
see
on
it
the
now.
IVUS.
We're gonna rotate it.
So just...
I think you can see the balloon there on.
Can you do chroma flow on, please?
Is that
I
12
know there's not going to be
o'clock? Is that
flow,
12
but still.
o'clock? I don't know.
I think it's at 12 o'clock. That filling defect right there.
Turn the chroma flow on.
So
I
which
think that's the balloon right there.
All right, so how do...
So basically,
Yeah, sorry.
this is the length,
yeah.
and then if you
just
this
fire.
is the longest.
Yeah.
This is we want to go long.
Yeah.
Okay, and then just fire the needle.
Should I pull the wire back?
You don't have to. That's a support wire. So the needle's out. Give me the.
I don't think it went.
You didn't
Give
get
it chroma flow.
Pop the balloon, right?
No.
Chroma flow.
Maybe you have to rotate it now the other way.
Yeah.
Right,
So
maybe
see,
there.
that's it. You can see the luminal flow is right at 7 o'clock. So you need a chroma flow to do this. There's a.
Sorry, came back. Can you push it up?
Well, now it's.
Right there. Okay. Let me see if. Didn't pop.
Yeah.
There you go. Maybe a little up.
Lower or higher?
Higher, I think. What do you think, Michelle? Right?
Yeah, right there.
Like you
That's
kind of
enough.
see the.
That's something. The lumen's here 3 o'clock. So get the lumen at 12. That's it. Stop.
Okay.
Now you fire.
Right there.
Yeah, now you fire.
Now you push the needle up. Let's see if it pops. Yeah, one tough balloon, man.
It's right there. See your. So here you're actually in the lumen. You can see that part.
So maybe drop the balloon and see whether we can push the wire up. Give me a command wire.
Give me a back feeder command wire.
We have it. We have a command wire here somewhere.
Like it's in something.
Yeah, no.
Something.
And I can see the wire, but I guess question is that the wire just doubled over.
Can you clean this up?
Here's your command.
Give me a command wire, Dame. I don't have one.
It's weird.
Remember, you have to feed the wire because this wire is not going to drop.
No, agreed. I think we're in something. It's just a question of not getting the command wire in.
All right.
And then, but I think you'd have to drop the
Me.
balloon as the command wire goes up.
Yeah, the balloon should have bursted. You're right.
Yeah, it should have popped.
Yeah, if you're in
Yeah,
it,
it should have
burst,
popped.
yeah.
Yeah.
Yeah, but sometimes the balloon doesn't burst, Kumar. In my experience, they make these balloons pretty tough.
Give it to you now.
Yeah, I would just drop the balloon in the sack. Okay, wet one, guys, for me.
It's interesting. You can see the respiratory variation on the IVUS of the
Yeah,
wall
yeah.
there. It's your luminal.
Oh,
We're in some lumen, right?
Oh,
Yeah, you're definitely in the lumen. That's pretty nice to see. No, you're
right.
definitely
Yeah.
a good lumen.
Yeah, not an arterial lumen.
Ready? Okay, let's drop the balloon now. Let's see if this just goes. We're just dropping the balloon, and where's my command wire? It's coming at some point. It'll come, I guess.
Yeah. Not yet. Keep going. Give me.
There it is.
There it is.
Nope,
Huh?
not quite. Nope, definitely not.
Although, yeah, let's see. So, but it looks,
You want to try to rotate again and
yeah, because if you put the wire out, just so you can use that to sort of orient
Yeah,
yourself there.
it's similar to that catheter though, where that catheter is, the channel you
try
just
here.
had.
okay.
I feel like you need to be further over, right?
Okay. Go this way,
That's better. Yeah.
right there.
Yeah. That's it. It's at 12 o'clock. Now you technically should be facing the lumen.
Nope, not quite.
No, so see if you want to get the balloon down for a second and let the wire go.
Let's see. I
It's not going.
mean, it should go though, because it's a 14
know.
millimeter lumen.
No.
No, guys.
No.
That's why I was saying, with this kind of a target, honestly, a beadback, I think, has 11 millimeter needles. The farther throw that you can angulate whichever way you want. Maybe something more robust is what you need. We've tried 2 different re-entries that are almost similar.
Yeah.
Well, we definitely hit something there, guys. Okay, now I'm in. Yep,
Oh, that's.
Yeah.
we're in.
Move forward.
There you go.
Just keep going.
We're
See if
definitely
it
in.
goes. Just
There you
goes.
go.
Yeah, we're definitely in.
Yeah,
Yeah, we're
definitely.
definitely
We didn't pop.
Nice job.
We didn't pop the balloon.
Great work,
but
guys.
Yeah, we didn't
work.
pop the
You just
balloon
kind of
though.
went next to it.
Yeah,
That's
to the
great.
Yeah.
Well, let's make sure, Rahul, you check up top. Make
Yeah,
sure you
let's-
think you're in. 'Cause-
Yeah, we don't want to be somewhere
Yeah.
we're not supposed to be.
Yeah.
Do you want to? Yeah, well, we could have
Where's the
introduced
wire?
into this
You're up there.
catheter
You
and
can
go.
kind
Yeah.
of see the double density of
You
the.
can see it? Is it going?
Looks great.
Isn't that your?
I don't know where it is.
Isn't that next?
Push it up. Keep pushing.
I mean,
Looks
it's
like
right
you're in
there.
the right atrium now.
Yeah,
Right
all the way up.
atrium, right?
All the way up.
Yeah? I mean,
It's like right there. You can see it doubled over.
So it's not. It's
Yeah.
not
Let me
okay,
take
so
my
it's
wire
not.
out.
Yeah.
Well, we're gonna
Let's
find out,
follow it
sir.
all the way up.
Take, walk it out?
Yeah.
Okay.
No, it's looped right now. Hold on. It is looped.
I'm just going
That's
to.
fine.
No, wait. It's looped right there, PK. Wait.
Whose wire? Oh, that's your wire.
No, my wire. Yeah.
Yeah.
No.
I'm just walking this back.
That is not my wire.
Put a catheter
The
in.
wire is looped.
Yeah, it's looped. So we're gonna put a 4
okay.
French glide catheter.
Yeah. What I mean to say is like, yeah, if it
Dame, let
advanced.
go of the IVUS for me now. Undo the IVUS. I just, now we got to detach the IVUS. Yeah, so sometimes, I always tell my fellow, that even a blind squirrel can find a nut. And that's basically what happened there, right? We just kept poking.
Just poking. Keep
Yeah.
poking.
So,
Hopefully it's in.
obviously, which wire is which? We
I mean,
don't
it went
know.
pretty easy. So
It did. It did.
we're gonna
All
find
right,
out in a second.
so we
You
have
have
to
that 4
figure out
French
which
glide
wire
catheter.
is which.
This is the one that's still in him.
Okay. Oh God, Flora. Hopefully that didn't come out.
Nope, you're still there.
Okay, good. All right.
that 4
Give us
French
the
glide
4
catheter.
French glide catheter.
It's
Okay, 1 second. We're getting a catheter for you.
yeah.
So now the work starts, right?
Well,
Yeah,
now,
exactly.
yeah. Well,
Yeah.
listen, that's why I
Snare
was very
first. Make sure you have it.
sensitive to you guys, because I know. But I'm glad without you guys talking us through that, I think we would have not gotten through.
Yeah.
Thank you. This is long enough, Dame?
Yeah, should be.
Yeah.
Yeah.
I think the key thing here too is where you guys did the puncture, rather than puncturing along the kind of that more
IVC.
oblique segment of the iliac
Yeah.
vein. You went for the IVC because it's a little safer.
Yeah.
Because you don't have as many surrounding structures you have to worry about. So
balloon's
that was
still
a
up.
very good technique.
Yeah, you can.
Let's come when we come down with the balloon.
Yeah.
No, yeah, you're down now. Uh-huh. Wow.
It's tight.
Let's walk the balloon back, I guess.
No, it's just because it's not a lumen, right?
Yeah, that's true.
It's not gonna work.
You want a
You have a
balloon?
will that snare go into
Oh,
that
and
sheath from the catheter from above? Because then you have a rail.
yeah, we're gonna upsize. So
Yeah. That's what I'm thinking.
So now for everybody at home, we made a hole in the septum, but we cannot push the catheter through. So now, Kumar, you're saying snare because you don't want to balloon a segment that's external,
so we're
right?
gonna upsize that sheath.
Yeah.
Well,
Or
if you
take
can,
an overnight,
if that snare that you had from below can just
catheter
go
and
from the
just try to
catheter
push
from
it.
above, you can create a rail.
Give me an overnight
just to
navicross.
push from below.
Yeah, actually, we
Got
could just take an 018 Navicross.
Yeah, just take an overnight navicross and then try to see if that will.
see if that goes
Okay,
up.
open
yeah.
it, Navicross, guys.
Yeah,
Oh, give us a Trailblazers, fine, whatever.
something.
Whatever's good. Thanks, Michael, for cleaning up. Okay.
Yeah, but hopefully everyone sees these cases can be really complicated.
Well, listen, this
Yeah.
is why we're doing it. I mean, guys,
That's a great
I can
case
take
to
any
show, yeah.
O1A catheter, please, anything.
Yeah.
You can give me Cook, you can give me anything. I just need an O1A catheter.
Yeah.
You can do a low
So-
profile balloon too, coronary balloon or something too. if you
Yeah.
have
Yeah.
Wow.
I mean, truthfully, I think this shows also the teamwork. Michael, flush this, please, because if you don't have a good team, you don't have a great tech, you don't have great nursing.
Yeah.
It really becomes very difficult. Look at the patient under. She's not under anesthesia. She's basically, conscious sedation, sleeping well. So it's a big thing.
Yeah.
Go to
What do you
hemodynamic
want?
monitoring. You got the wire, brother. Don't pull the wire out. You got it.
No wire yet.
Cool.
Okay, I got the wire here.
Yeah.
You can
You got it.
pull it down.
Yep.
Pull.
All right.
Push it to him.
Got it?
Sorry, PK, but most people don't get to have three experts doing one case together just to give you a reality check.
How much have we given already? 10,000?
Oh man, look at this.
It's tight.
How much have we given already?
You want me to?
Yeah, right. Maybe
Real?
you have to balloon it.
Yeah, we have to balloon it or we have to snare it from above.
I would snare it to have a good strong rail. Even if
Yeah,
you're
yeah,
gonna balloon
yeah.
it, you're gonna
Yeah.
want a rail.
Yeah.
We've given 60.
Yeah,
I mean, if
I
you
would
snare it, then
snare
you
it
can
too,
do
guys.
Okay. All right, let's snare it.
You can leave this on.
Yeah,
There.
he's only
I'll leave it on.
Then we're
So we're
gonna
gonna upgrade
upsize.
the
You
sheet
want to
up
upgrade the
top,
sheet? All right, give me a short
and
smooth
we're
super
gonna snare. So Kumar, sizing of the snare, same snare, different snare. What do you do?
I mean,
It's the same snare.
it depends on what catheter you have from above. If that
What's
10,
that
I don't
sheet
know
you
if that
want,
10 will go through
Or
that
29.
catheter you have. Otherwise, you have to downsize.
Or actually, if you have a
Nine.
7 French destination, you can just bring it right down, right?
Yeah, we have a 7
Yeah.
destination. Give me a 745, please.
Just put the sheet down. I mean, I think
Supracore
whatever
and a
snare you have, that'll
745.
fit's fine.
Mark.
Yeah.
So right now I'm just cleaning up here
And
for
also,
us.
and also, the snare will tell you that you
Long
are
supracore.
truly in the same place anyway. So-
Yeah.
yeah, I
You
know
haven't proven
because
that
you're right. To this moment, we don't know if we're
745.
truly in the same place.
Yeah,
Yeah.
we're making an assumption here.
Yeah, so we're making everything up till we get there.
Rahul, if you just twist that catheter from above, you'll know if you're hitting that wire anyway. That'll kind of
I mean, I think
Tell you all
we're
you need to know.
in because it's you can see the wire.
you're seeing it move, right? Yeah. Okay.
Yeah,
Yeah, it's flipping. All right, here.
Pretty good.
I have the.
Yeah, I mean it's going up into the IVC, right? Like,
All right.
Yeah.
we're definitely
there
in.
you
It's
go.
just,
Yeah.
but we need the rail just to cross, right?
You need a better
right.
wire, some rail.
Our
support.
ACT last ACT was
Yeah.
252. Should we give 2,000? Okay.
Yeah.
So again,
Okay.
the team, letting the people at home. So you've got to have the ACT. Somebody's thinking of it.
Sorry, I'm going to
Because
demat for
Dr.
you.
Patel and
Michelle.
myself were working with this with Dr. Kapoor.
you got
Nurses
it?
are really
Yeah, I got
thinking
it.
about the ACT and the hemodynamics. And so far,
Leave the sheet.
blood pressure, heart rate is stable.
Sorry.
And the patient is obviously struggling now with the neck because we're putting a 7 French sheet in the
Sorry.
neck.
Give me the dilator first. I want to go.
I think it'll go.
All right, perfect. Give me the sheet then.
Yeah.
So
Give me
now what wire is
pan
that,
up
guys?
all the way,
You
yeah.
got the amplats up top?
It's a
I have a supracore.
Supercore is fine.
Long supracore.
Yeah.
Yeah.
There you go.
I want to.
Our Gore rep out there. Do you
Yep.
have 14 Atlas Golds here?
Can you get 2 more 14 Atlas
have-
Golds?
We have one, so we just dropped the other.
Yeah, we need another one. Can I get another Atlas Gold, guys?
1 second. Let me give you a roll.
Oh.
Let me give you a roll.
In the meantime,
Errol,
what
can
I'm
you
going to
come
do
up,
is I'm
please?
prepping the 2 balloons.
I know. Sorry.
There we go.
Lo siento. Respira.
Presión, por favor.
Okay.
Go straight.
So what size sheath you putting in, Rahul? Michelle?
So just
Seven,
we're gonna put a
Give me
7
5
destination down, right?
Do a
Just so we
Okay.
don't have to keep fighting this.
Come
Yeah, yeah.
straight. Come this
Yeah.
side to do a neck.
Yeah.
Sorry. Give me a dilator.
Yeah, she didn't like that.
Yeah. So what, I'm gonna have to do a neck then. Okay. Give me a neck. Yeah.
You can actually just use the
Probably
9
the neck.
dilator too.
Yeah, I'm gonna do the neck right now.
Blades open.
Actually, I don't need this. Do you have a
Hold on,
balloon,
hold on.
like an 014
Yeah, we have
balloon?
a coronary balloon. You want, or what balloon would you like?
Yeah, like a
4-0?
40.
Give me a 4030 coronary balloon.
You just want to walk this
I
out.
got it, brother.
Get, hold on.
Oh, the wire's
Sharp.
already way up.
Yeah.
Okay, good. All right.
Keep it ready.
So we just got a snare
Hold it.
4030 coronary balloon.
Then we can just, once he snares it, we can just balloon it, then follow back with
Sorry.
the and then exchange for the implant.
I know. Okay.
Respira. Todo bien. Todo bien.
That's
I
enough.
think you can see kind of we're gonna have to really vessel prep that confluence, you know.
Oh yeah, it's gonna be ugly.
Raul, you
yeah,
happy
it's
with
gonna
that?
be
Yeah,
gonna be
yeah.
tough.
Perfect.
It's gonna be
So
tough.
then what you would do next is take that snare.
Yeah, let's
you
do.
go.
Give me flash it. Put the
So
snare on the
4030
supracore.
coronary balloon going in now.
Actually, you don't even need to put it. You could just put it naked right
Okay,
now because it's
fine.
just
Yeah,
in the
yeah,
edge.
just
right
put
there.
it, just put
Okay.
it straight. Yeah.
Yeah.
Okay. All right, here. Give me the flash. Let's flush the sheet real quick. You want to take the same snare from below?
Yep.
Okay, perfect.
So on my end, Kumar, I'm just going in with the 4-0 balloon just to help in Rahul here to get it ready.
Flush.
Perfect.
4-0 balloon in.
Snare. I flushed it. I just need the
Straight
snare.
down.
We don't have a snare.
I need the
PK,
catheter.
is that
and the-
a 018 balloon or 014?
No, it's a coronary 014 balloon. It should have crossed.
Damien,
four,
can we get
yeah.
your snare?
Look at that. Look how
Snare.
difficult that is. Even an 014 coronary balloon is having trouble.
Hold on. Give me
We're
the.
getting it. We're getting it right now.
What we got?
So the same snare we used, no?
We're just
was
balloon
trashed?
our way
Okay.
back a little bit, and then well,
Snore should be up in the back, no?
No, it's trashed. And we'll leave it.
Thank you.
All right, I'm just going to go up with the 014 balloon here. You tell me when, Rahul?
yeah, just go.
Okay. Going up with the balloon, guys.
Give me the micro catheter. No,
It's a
no.
little bit more proximal, I think, than we crossed.
Yep, I'm just gonna bring it down, right? Yeah.
So again, it's a monorail balloon.
Give me the
more
snare.
pushability. There you go. There's our.
We have floor on, right? Okay.
Yep. This is 12 atmospheres. And then over here.
Yeah.
Okay, good snare.
That should,
Well,
help, that should help
atmospheres.
a lot. Yeah.
How's
Yeah.
it feel, PK? Is it tight?
introducer.
Feels tight?
There's
It's
one more,
tight.
Yeah, it's one more
It's
place right
definitely
here.
Get it all the way.
tight,
Pull,
Srini.
pull, stop. So we do this.
Okay.
The micro catheter.
All right, so I think
introducer.
we're
Perfect.
You good?
yeah.
You want to see if push the deflated balloon up, see if it goes. Because it'll be a good test for you. Because this is
No,
obviously.
it's bending here.
yeah,
It's
low
actually,
profile. That's the problem. So
yeah.
there, one more time here.
Okay.
Okay, so let's see if you can snare our wire. You want to leave the balloon up? We can.
Yep.
Yeah.
Leave the balloon up.
Yeah.
Okay.
So he's further.
Hey, you want me to
It's
pull the
pretty
snare
high
back,
up
or you're
there.
gonna pull the wire back?
Yeah, I'm just. There's my wire.
Yeah.
Okay. I think you have.
No.
No.
No, you had it.
Let me pull my. No. Let me pull my sheet back. Yeah.
So
Okay,
why
I'm go-
snare it so low? Why not snare it higher?
I was gonna. That's why I asked Rahul.
Yeah, you can snare it here. You can snare it.
A bit higher.
Yeah.
Because you know you're in the atrium up there.
Yeah.
Maybe not snared in the atrium, but
You got it. You got. You
There
got
you
it. You got it.
Yeah,
You got it. Let me
yeah,
get.
yeah.
Yeah.
nice.
Hold on.
So you might as well just pull the snare out. Now I'm gonna feed the wire because it's gonna come in through the catheter.
And I'm just gonna push the catheter down to really make it that hair.
No, just pull
Just
the
pull-
snare, brother.
Yeah,
I know. I am.
Yeah, just keep
I
pulling
just don't
snare,
want to
yeah.
lose it.
It's okay. You're in there. It's okay.
Cycle a cuff, guys. Tell me when you're externalizing.
Oh,
the
see,
cuff.
with the wire
You got the
lost.
wire?
You know, it's lost in between. That's what I said.
Yeah, it's okay. It's coming out the.
Let me see how far it gone, Kim. Is it in the sheet?
Yeah, it's in the guide cath.
Do you see it, Vishal?
No, that's what I'm looking at. It's going up to my cat. I just want to see if I can. I think I should pull up my. It's right there.
Yeah, it's up the guide cath. Right?
Yeah.
Yeah, so you could probably just pull.
Pull my catheter out.
Yeah.
Yeah, that's what I'm gonna do. All
Yeah, push the wire.
Yeah.
Yep.
Exactly.
right, good. I got it.
You got
Give me
it.
a mosquito,
Okay.
There
please.
you go.
So now I'm done with the balloon here.
Nice job, guys.
All right, next Next step is go in with the catheter.
We
Okay,
gotta.
I have it clamped here, so you
Cool.
can do whatever you want to do.
Perfect.
Okay,
I
here's
would
your.
upsize your wire.
Do you want-
I would upsize your
Yeah.
wire, right?
Yeah, we gotta.
So what we're gonna do is we're gonna change for the glide catheter and then upsize the wire.
Yeah.
Here's your glide.
Yeah.
Is this long enough for you?
Yep.
Get us a Navicross 035.
Well, we're not gonna. We don't need to externalize the.
No?
Well,
Probably better, bro.
You should-
Yeah.
Probably
So then-
should. You probably should, right?
Yeah, exactly.
All right, 035 Navicross is coming.
The issue, you might want to get your sheet down, because otherwise you're not going to have enough room, right? I'm assuming you have a lot sticking out the neck. Is that right?
I guess 15. We have enough length, though.
Yeah, we have enough length.
Get rid of the Outback. So we're getting rid of our Outback and our Pioneer.
Don't need that anymore.
Then we actually can have the correct end of
So
the
then,
wire.
I've got the Atlas balloons ready for you.
so then what we'll do is actually we'll balloon to 8, and
You
then
need a new 80.
no, we have an 8.
We
We have
have-
2.
We have two of them.
We have an Ranger here.
Huh?
So we'll balloon
have
to
it?
8
have
on
the
this
other one?
side, just along the tract,
Okay.
and then we can take a venogram and then see what's
That's an
going
8-0?
on, and then decide if you want to pre-dilate to 14
And then
or on
deploy
both
the
sides,
stents.
or just
Okay, ready?
start
I got
laying
it.
stents.
Rail.
Yep.
Go. So this is the 035 Navicross now going into the. I'm holding rail here for Dr. Patel. Yep, there it goes. Beautiful.
Up.
Into the sheet.
And now I don't need to
Now
watch
we're going to
it.
externalize it and put a supercore up, or what wire would you like?
Is it coming out the back?
I have to, not yet.
Yeah, Unicrit.
Yeah, it's pushing my sheet back. Okay, I'm going to hold my, it's out, it's out, it's out.
cool.
I
And
got
now
it.
let go of the wire. You can-
I did.
okay, and I can pull out the wire here. Give us a new supercore, if we
Yeah.
don't have it.
Or actually, we're going to take the Amplats.
Amplats is fine.
Yeah, so because of the deployment mechanism on this Gore stent, the recommendation is to use an Amplats
Yeah.
super stiff.
Oh, really? Okay.
Yeah.
I did not know that.
Yeah.
Yeah,
All
You
right.
need a really stiff wire.
yeah.
All right. So Amplats is going in. Now we're going to need an 80 balloon.
Okay, I have the amplants right here. Hold on, let me mosquito it. Perfect.
Just
Good.
mosquito it.
Got it, go, pull.
All right. 80 balloon coming up.
And then actually,
That's a 14 there.
we're going to upsize this sheath.
What's
Okay. What
yeah?
size?
What size
Um,
sheaths do you have in the groin?
Right now, one side's an 11, one side's a 16. We're going to put a 11 just to do our pre-dill, and then we're going to
11
switch.
sheet.
Yeah.
I have it right here.
We have it.
We're
Yeah,
going to
okay,
switch
come.
one to a 14 dry seal. It's a pain in the it's got to go on this one right here.
Yeah, this one.
It's a pain in the
And
butt
are
to
you
work through
gonna
a
use,
14 French dry
a-
seal.
Are you going to use a double barrel technique, or are you going to use a primary IVC stent with 2 stents into
Yeah,
it?
brother.
So yeah, so the recommendation
That's my fault.
So the recommendation for this is.
Thank you.
Nick, you need a Nick?
There you go.
Yeah, no, I got it.
Okay, good.
Is to do IVC stent and then
80 balloon.
Pant legs
two
into it. Yeah.
pant legs. So basically, looks like an undergraft.
So 80 balloon going in on the left side.
And then so we'll do a venogram and then start figuring out what stents we're going to place where.
right. Sorry.
Just
Yeah.
one, right? You just need one.
Go.
You just
Gotcha.
needed the one.
So normally we would do bilateral, just kiss the 8s down, but since we already did 14s, we're going to go all the way up to the top.
Go ahead.
You put my
You're in
sheet
the
back?
sheet now.
Yeah, you got to back up the
All right,
sheet.
let me get my sheet back.
So we know the renal vein somewhere around there. Keep going. Is it hard to pull?
Yeah.
Yeah, here, let me pull the.
Perfect.
balloon out.
Yeah,
There you go.
better. Good.
Keep
That's
coming.
enough?
Yeah, keep coming.
Keep coming? Okay.
Yeah. There you go, just above the V.
Good.
That's good.
Good. Excellent.
So normally we would do kissing balloons because you'd cross, but you can actually come
There
back
you
a
go,
little
bro.
bit more with the sheath. I don't think we need this 014 wire anymore, right?
Nope. I'm gonna get rid of everything. Going up. So what's nominal on this balloon, guys?
You can take it like 12, 14, somewhere.
Uh-huh.
It's fine. Because we're just, basically all we're doing here is just creating lumen for the stents for later.
14.
So
So,
Raul, how are you planning to size this IVC?
So we kind of measured, we cheated. We measured before on the CT scan. And we got basically about 24, right? Again, just because everything is,
that's the problem right there.
yeah,
Yeah.
everything's out. I'm not terribly worried that it's going to fly. We're going to actually, just in
Yeah.
case, right? You can take it down.
14.
We're going to stent over the externalized wire so that
Good
if,
idea,
God
yeah,
forbid, it
yeah.
did fly, we're set up to deal with this.
Right.
All right. So there's the 14s going up.
Yep, we're going to take this actually, we're going to balloon all the way down.
Yep. So this is a great case showing everybody the challenges
too
that you
much.
face. You okay?
Yeah. Yeah.
And again,
Oh, it's a fantastic case. Kudos to you guys.
yeah, this is a great case. So, all right, 14 again.
Yep. Just down.
Uh-huh.
I'm gonna give you a little bit more.
A little bit. This is good. A little down.
Yeah,
Okay.
yeah, that's
Uh-huh. Good.
It's great to show because Srini was just thinking about doing this in his OBL, and then he decided not to when he saw how much equipment you guys were using.
I love it.
I definitely wanted the 2 reentry devices, plus the IVIS and everything else.
Listen, that's part of it. Honestly,
I
it
love
just
it.
it shows. It's funny. We did a live case in Arch, and we thought it was going to be just a straightforward case. We ended up embolizing into the internal, ended up a bunch of stuff, penumbra, this, that, the other thing. And
So why don't we do a venogram
picture.
to see where we are, right?
You want to attach?
No, I think we can just do 2 hands.
Okay, 2 hands. Okay.
Yeah.
And the point I'm trying to say is that you have to be ready. You have to be
Do you have
prepared.
10 cc's?
Yeah, can I have
Yeah.
10 cc
all the
syringes? But
things
yeah,
that can
give some
happen,
better injections.
Yeah. Also going
Exactly.
through
We took
11.
on this
yeah.
undertaking with this young
Right.
lady, and and we have
So
to get
true.
it done, and that's what. Just very grateful for you guys, as well as Rahul, obviously,
For
for
a
giving us
second,
time. Ready?
Yeah,
All right,
perfect.
guys. DSA, you're on DSA whenever you're ready. You want to inject one, brother? Let me
Yeah, I
inject
got it. Yeah, I got it.
All right. All right. The money shot, as they call it, right?
Well, yeah. It's going to look like
It
shit,
often looks
but
terrible still.
oh,
It's
it's
going to
a-
look terrible, yes.
we're coupled.
You're coupled off coupling?
Yeah.
Okay, good.
Good. Okay.
Definitely looks a lot better than I thought it did.
Yeah. All right, so
That's basically what we
but-
expected. So
Yeah,
Yeah.
yeah.
Oh, that's good.
But the right side actually looks quite good, right? So
Right
that's
looks good,
great.
yeah.
Yeah.
So what's the next step?
So we're gonna upsize this sheath to a 14,
Okay, 14 now. Dry seal.
and then we'll take the
14 balloons.
24. What did we say? 2400. Yeah.
Open.
We did 14. Oh, I see what you're saying. Yeah. Okay, so we'll put the 14 in then. So, do we have the 214?
We have one 14 here. I have the other 14 outside.
Yeah, thanks.
So you're going to demarcate the renal vein again, but taking a
We
catheter
will.
up,
So we're
or-
going to do that next to your catheter there.
Yeah.
Although you can just sort of blast your catheter, your sheath from a neck, and we should
Yeah.
be able to see it. Again, kind of like the old Gore endographs, like you can do the sort of controlled release where
Right.
you start pulling some of the knots, let it flower, and then kind of trying to
pull
cinch
it
it down.
back. Yeah.
Yeah. And if it encroaches on the renal vein, it's not the end of the
Okay.
world.
Yeah. Sure.
Do we have
14
lidocaine?
sheets ready, brother?
Yeah. Put it on.
She's just feeling it a lot in her groin,
Oh, lidocaine. Can I have more lidocaine, please?
and then there's no.
I got it.
It's
There's no neck.
interesting. Unlike aortic repairs, we don't try to go often 1-to-1 with IVC reconstruction.
This was
We tend to
lidocaine,
get
right?
A laminar
you get
flow
more-
to
this was
whatever it
lidocaine.
is.
Huh?
The veins have so
Yeah,
much
I can give it,
compliance;
right?
it's hard to be sure.
Give me fresh. Yeah.
Open the other 14 Atlas balloon. The one is here, one is there.
the interesting thing about this stent too is that it's not. They don't really classify it as open cell. They call it open network, right, Rahul? And it's got
Yeah.
kind of
Yeah.
an interwoven nitinol wires.
Actually,
with
so
kind
they
of
want
a
us to pre-dilate. So while we wait
PTFE
for everything, why
over
don't we
those
just?
wires.
8 up.
But it's still,
I mean,
it's
14
still
or
an
8-0?
open network.
14s.
Okay.
Perfect.
Yeah. So
Here, I'm
it's
going to
good
do a
to
little bit of lido.
yeah, that's it.
Oh, that's it.
Yeah.
Sure.
Sorry, my bad.
Just that's it.
So we're going to just numb up her groin. So, the recommendation, I know it's a little scary, is to actually pre-dilate to what you're going to take it to. So we're going to pre-dilate bilateral 14s gently.
Yeah.
All right, one more. Sorry.
Yeah.
Okay, here's 114 going in. I got the wire.
So these are, you need the high pressure balloons.
Yeah.
All right. Yeah.
And you have to keep them up for a short period of time because really the vessel prep is really key here, like you said, Rahul.
Yeah.
Yeah,
Give me
exactly.
an end deflator, guys.
Yeah.
So we know we're kind of
Especially
good
that
there.
bifurcation. That bifurcation
14.
is going to be.
Yeah, exactly.
This is great because I think
Right
finally having a venous type stent that fits that size criteria for the IVC that we can reconstruct, and the partial
Yeah.
PTFE with
Any
this
reason why
without
this is not
jailing off
coming
too many
out?
things. I think this really will
Yeah.
enhance our iliocaval stuff that we struggle with a little bit.
Yeah, I mean, IVC stents are always the most
Oh, I got it.
angst. Well, not the most,
Yeah.
but cause me a lot of angst. 'Cause I'm always worried they're going to fly. Do you try to put a
Exactly,
20, make it look pretty, or just double barrel it, and then you have a lot of stent length and weird lumens, and it's never
So
really.
this is the.
These are 214 Atlas Golds
Oh.
going up. One. One is longer than. Oh no, they're both the same length. Okay, that's cool. All right, so we're just gonna go, just to bring it to nominal, right? We don't need to really.
What's nominal?
8 should be. 6.
One's not going up because I didn't turn it for him.
Oh, thanks, man.
Oh, come on. Hold on 1 second.
This thing is unbelievable.
Yeah, it's a
You didn't give me enough dice,
24
guys.
stent is going to be in
Yeah,
the
they
back
have
seat.
Where's you have another one?
Here, PK. Oh, okay. Let me hook this up for you.
Right in there.
Right?
Hold on, let me go forward.
Yeah.
Now go ahead and open.
Go.
Can we get some more contrast on the
Okay,
bowl?
you ready?
Some more contrast on the bowl.
Okay, there we go.
You know, PK, Rahul made an excellent point that I think you can't
6.
impress upon enough is having that wire through and through, externalized. You'll only protect yourself from what
Yeah,
we've seen
expanding
some
at all.
issues with stenting
Now it's going to
that
go.
migrate.
No. No.
No, it's coming up. It's
Yeah,
coming.
now
It
it's
just
starting
takes,
to.
yeah.
Yeah, just take it to
Laura
like
said
6.
Yeah,
8,
6.
Yeah, perfect.
Okay, down.
Fluorescent.
Fluorescent.
Yeah, perfect. Go, 1, 2, 3 down.
So we'll do basically 14s all the way down. Right?
Okay.
It's tight there, and then this one we have to walk back. All right, go ahead. So yeah, this one is a little bit more sensitive to vessel prep than some of the other stents. The other ones we used to just balloon it so we can get the stent apparatus up and then go to town. You can see that
Oh.
tight side on that.
Wow, look how tight that is.
Yeah.
Is that even opening? Yep, it's not even opened yet. Look at that. Look at the May-Turner
No.
configuration there.
Yeah.
Wow.
Like yeah.
Wow.
There you go.
That's good.
There you go. That's now 6.
Probably you were
Alright.
having trying to cross through there. That's exactly
Yeah, yeah,
what's
Six
wrong.
exactly.
right there.
Yeah. 1, 2,
Down.
down.
All right,
That is tight, guys.
we're gonna kind of hit that again, just on the back
Yeah,
end.
I would really, because that's going to really hurt you after the fact if we don't
Yeah.
prep it well, you know?
Right.
Yeah. Yeah.
And it's so funny, Srini, because in the arterial side, we talk about vessel
then
prep
go
all the time, but in the venous side, it seems to be just as important.
Yeah, 100%.
It is, especially for these chronic venous occlusions. Like you really need
6.
to get.
I'm not even there.
Yeah.
Yeah.
Yeah, that's 6.
All right.
I saved that.
You know, it's interesting, Rahul.
Yeah.
You're getting
Right down.
relatively symmetric inflation. I mean, look at your guide wire within the balloons.
Yeah.
I mean, that's pretty
Yeah,
amazing
it's
with everything that we did just to get.
Yeah. Okay, you can go up on your own. You don't need to go double together.
Yeah.
Okay, go ahead. Vishal.
Again, 6 atmosphere. 6 atmosphere.
Yeah. Again, this is.
Yeah,
You know,
just,
I feel a little more
fluff.
comfortable once we have the stents up, but this is
Yeah.
just enough to get the stent
yeah,
to,
they're right.
to pop. Right.
Rahul, how far down on the externals do you remember that you feel like you're gonna have to stent? Was
We're
it
gonna
the whole
basically
way?
have to
I think
go-
it was open, right?
Yeah. Yeah. Parts of it are open. We'll figure that out. The
1, 2, 3, go.
you know, we're probably gonna have to stent to basically where the sheets are
Yeah.
on both
Yeah.
sides.
Yeah.
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 And then we'll recheck it. And then that's actually where IVUS is helpful, right? If we need to extend the stents in the bottom end,
Right.
when it becomes a little
Exactly.
funny. But I think we're good here for both sides to get everything
And now
up.
we need the dry seal, guys.
Yeah, we're gonna put the dry seal up on this side.
You made a nick over here.
Nope, not yet. You want to walk
Okay.
this?
Yeah,
up,
yeah. I want this hand.
So, you know,
Save
ideally,
those balloons.
you know, you can externalize both wires. But the problem is, if you do the Y configuration, you're gonna have to pull the wire back out to do it. So,
Fluoro for a second. It's still not there.
Yeah.
God damn it. Why is it so?
A little bit to relieve the.
Yeah.
Yeah. There you go.
There you go.
All right. Once we make the nick, 14 dry seal is ready. Great. Great. All right. Now we got the stent ready, guys. We're just going to keep the balloons in the back to post dilate.
Nick.
Okay.
Actually, I don't think we need to make a nick. I think we can just go with a Kelly's. Do you have Kelly's? Yeah, here we go.
PK, just one question. For all your cases signed, do you always have 3 experts doing cases together? Is that just how
Yeah,
it
you know,
works
that's
there?
why I want everybody to travel from Chicago to see Rahul, me, and Vishal. You know, Kumar.
I didn't know this. I didn't know there was a possibility. I didn't know there was a possibility.
No, I'm saying you struggle on your own. We struggle together. That's the difference. Oh my God.
That's awesome. Great seeing you guys do it. Such a tough case. Yeah, that's awesome.
Okay.
No, it's really, I'm telling you, I'm so blessed, Kamar. I've always told you this, working at Sinai, we've been so lucky
Do we have the syringe for this?
to have such a, we
It's
have
not a
it,
bloodbath.
to have such a,
Yeah. You want a regular syringe or?
No, there's a 3cc syringe.
Where
It's
is
right
it?
there.
There it is.
Oh, okay.
Sorry about that, guys. So to have that integrated approach, it's been really a blessing. It really has with both vascular surgery and IR with
Let's
Rob
get the
Cole
other,
and
this one. Oh.
vascular with Peter and the gang there. It's been incredible.
All right, you just pull the dilator.
Yeah.
It's the wire's pinned, so on the other side.
Right. It's all right. We're all set here.
Okay.
Okay, cool. So let's get the stent up on this side, and then we're going to take 16, right?
Stent.
Oh, 14, sorry. Yeah, 14, sorry. You're right, 14.
So this is the IVC stent?
This is the IVC stent. So it's a,
20.
yeah.
So we're going up with the
Tell
stent.
us,
Obviously,
tell us what
ahead.
size you chose, Rahul. What size?
It
you
shows
chose?
a 24-100.
got the wire.
Oh.
A little tough to go through, and then it goes.
And look at the vessel prep there. Really helps.
So actually part of it is the
The sheath from the other
sheath
side.
on the neck. If you floor Vishal, I'll help.
Yeah, outflow. Sorry. Oh.
Okay, so
Sheath is bleeding.
oh, that's
Good.
so let me take some of the wire, the Amplatz wire.
You want the wire? Okay, coming to you. Pull it.
There we go. Okay.
Okay, you're
so now
good.
we can pull the sheath back.
Uh-huh.
Do you see the destination on there?
No, it's
Yeah, there it is. Okay, there. Yeah,
yeah, right there at 4.
cool. So
You want to inject through that now?
Yeah,
See
let's
the hepatic
just
vein or
get it
not
up.
yet?
You want to push the stent is easily going up, so that's the sheath right up there.
yeah, I thought it was sort of near the V
Yeah.
So we're gonna inject through the sheath up top, right down the hole,
destination.
right?
Yep.
Push the syringe, dude.
Oh. This one? Unlock it. Oh, dry seal it. Yeah.
You have to do it from this side actually. The run. Actually, can you pull the sheath down, the stent down a little bit?
Oh, pull down.
Because it's in the mouth of the.
You like it? More?
Yeah, that's good. Just so we can see.
Yep.
Okay.
All right, ready, DSA?
Yep.
Cindy?
Wow.
Okay. So that's
Much better picture. Wow.
yeah. So we kind of need to be at the R, right?
Yeah.
Yep.
Yeah.
Yeah. Okay. Cool.
Okay, I'm holding.
It's gonna drop on us a little bit, so
Correct.
I'm gonna go up a little bit higher.
And then you pull back.
Yeah.
So is this a pin and pull deployment or just like a
I think we're gonna go a
cloth?
little higher, Flora.
Yeah, I was gonna say. You
Like
think
the
you're
original
left
the
full
string.
common, or is it just a,
Yeah.
No, I think we'll be okay. Yeah, because we entered down there somewhere.
Okay.
Right. It's just the lumen.
You want to take another shot or you okay?
I guess we could take a shot from this side just to make sure. Vishal brings a good point. We have to. Don't want to have to recanalize through the struts of a stent, but I think we should be okay. Yeah.
Yeah, we are above it. Yeah.
Yeah.
Perfect.
We're above the bifurcation.
So again, for everybody, we didn't want to jail out the bifurcation on this side, so that's why we checked to make sure that this would be a true IVC stent.
All right. Everybody's good?
Yeah?
Yeah.
All right. So.
Kumar, you guys good with this?
Yes. Yep.
So
Looks
yeah,
good.
you're right.
So-
All right.
So the deployment mechanism is just a string pin pull. So we're gonna do this under fluoro.
Like a wire bond.
Yep, and there it goes. And nobody
Boom.
flew.
Well
Okay.
expanded, guys.
Long.
Yeah.
Good long arms. Good long arms. Rahul.
I know. That's only the 100. Wait till we get to the
Now when we come this way,
I know.
twist it, right?
Yeah. So you have to push up a little bit
Yeah.
with the mechanism and then pull down. Let's see.
So the idea is so it doesn't get stuck on the stent.
yeah.
Okay. Now I got it, right? Now we can walk it out.
Yeah.
So that's a very good, important thing for people at home because obviously
Go ahead.
you don't want to get caught in the strut there and then pull the whole thing
sorry.
out. There you go. Perfect.
That
Okay.
opened
So
up very
now,
nicely. That's good.
yeah. So now we gotta just rewire this side, right? So we gotta bring
Yeah, the right side.
this side down.
Hopefully we don't need a snare. Kumar's rooting for a snare. Oh, no
Listen.
snare. Okay.
It came in handy. All right. It came in handy.
It did.
All right. So I think we let's take. Normally you
Okay.
can measure, but I think we're just gonna take the longest 16s we have on both
16s,
sides.
long 16s.
Yeah.
Or 14, sorry, 14s. Longest 14s. No, longest 14s. That should be fine. Yeah.
So a little bit on as we're deploying this question for all you guys. surveillance, how do you survey this? And then anticoagulation / antiplatelet therapy. Anything for our people at home to understand? Don't all answer at once.
Sorry.
So I'll tell you
I think in terms of medical management, I
start with the left first?
at least
They're both gonna go
3 to
together.
6 months of anticoagulation
Watch
because you're
this.
dealing with
Yeah.
thrombotic occlusion. So I would suggest 3 to 6 months of anticoagulation, and I think you could make the argument, although the data is weak,
Watch
for
your
a
face.
single antiplatelet as well for
Yeah, brother,
1 to
feed
3
me.
months.
There you go.
Yeah, I like low
Keep
molecular
going.
weight heparin for these
There
for
you
the
go. Got
first month to 3. Raul, I don't know about you, but I like Lovenox
Yeah.
on these patients for the first few months with a single platelet, and then switch over to an oral anticoagulant afterwards.
So you actually give them injectable Levothyroxine to go home?
Yeah,
Below the
yeah.
right
For
line.
venous
Wow.
So
reconstruction, venous reconstruction, I think that seems to be what's been most prudent for us.
So and
I
you
mean, one
find
of
that
the
to be
thoughts,
better than DOACs? Better
yeah,
than
one of
the
the
Yeah,
thoughts,
at the
PK, is that there's a lot of inflammation after these types of
Get rid of
reconstructions.
this.
And so having that kind of
Mhm.
anti-inflammatory effect from the Lovenox in addition to anticoagulation that first month,
Interesting.
again, some weak evidence, weak data, but there's some expert consensus panels that kind of suggest.
Yeah, and we've definitely seen it. And also the thing is, I find that they're actually a little bit more hypercoagulable right after the intervention. And with the DOACs and everything, you don't necessarily get.
What's the first one? What?
Do you have to do it simultaneously?
Yeah, so I'll show you the trick to do
So
simultaneously.
everybody show his hands, please.
Probably the
So
ones with them.
as sort of low tech as their deploy mechanism, it makes it
Probably the
really
100 bullets.
easy to deploy both of them at the same time. So you unscrew them. So you can see I'm holding both of them together, unscrew them, and then this works because they're both the same length. But they're different lengths, it becomes tricky. But I can literally just ripcord both, and you
And it
just
doesn't move.
and don't move.
Nice.
Yeah, great
Yeah.
technique.
Great. Nice job.
Nice.
And they're both deployed at the same time.
I'm
So
just gonna walk these. Again, you have to watch the.
yeah. So
Same
which
thing,
guy?
push
This one
and pull.
first?
Uh-huh.
All right, let's see. You can pull.
I'm coming slow.
Yep, you're good.
No problem.
So again, some of this is also alleviated by the fact that we did a really good pre-dill.
Okay.
That's
The other
true.
side,
Yeah.
Rahul, you want to push it up?
Yeah.
Your it looks like the luminal gain is spectacular, at least
Yeah.
on this 2D
Oh,
image.
no.
Fantastic.
Oh, yeah, you got it. Okay.
Yeah, that was the old PK pull there.
Yeah.
It wasn't elegant. It wasn't elegant.
All right. So let's
You
see.
know.
What we'll do is we will do a venogram to see how far down we need to extend.
So this is where we
I need
might
some
need an
contrast,
IVIS.
just regular
Yes.
contrast.
So let's get an IVIS ready, guys.
We have it ready.
I think we're gonna have to extend the left side. So,
Okay.
Yeah.
Let me give you a nice.
Little die, brother.
Yeah, and I'm wanting some. Can I have some more dye, please? Contrast. Yes, thank you.
But this is gonna look really nice.
So
I
all
think, at the
nice,
end.
full.
And then we'll go
contrast.
back and then PTA with the 14s.
Right.
And then this time we can like really lay into it, right? Like really crush it.
So would you go with the same 14s or different?
Yeah, same 14s. They're high pressure balloons, right? So we used Atlas Golds.
Okay.
So there are not a lot of big high pressure balloons available. That is one of them that we use. I don't know of any other 14 sized. Ready?
Yeah.
Yeah. So this one you're gonna have to take down almost to the
femoral head.
yeah
Both sides.
The pelvic
looks like,
brim.
huh?
yeah. I think both sides actually.
Yeah.
Yeah.
I'm gonna redo
Pull
this
the
side.
sheet. Yeah, I was gonna. Here, let me give you.
So again, we didn't really go into it too much,
Meters.
but we made a point to when we punctured this to puncture as low on the open segment of vein as possible. Yeah, we're gonna have to basically do both sides.
Yeah.
Yeah.
Okay. What size would you go like?
Yeah. So what are my choices? I guess yeah. So I think we can do.
You put a 16 in there, right, Carly?
No, we put 14s, right? 14.
Oh,
Yeah.
14.
14.
Okay.
Yeah,
Yeah, you
so
can
I'm
go
gonna put
12, 10 or 12.
I'm just gonna put
right?
I'm just gonna put 14. I'm just
14.
gonna
I
put
would say
14.
14. Otherwise, you're gonna have offset. Yeah.
Yeah, a
Yeah,
lot of weird
yeah.
stuff. So the length,
14's
I think
good,
14 100 on the left, and then maybe. Honestly, I don't really care. Do you guys don't care about the overlap, right? Yeah. So just give me two 14 100s. It just makes it easier.
14 100s, guys.
Yeah. Just take all the guess out of it.
Yeah.
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 So,
So
She's
why-
got
so
big
why are
veins.
you
She's got
using the
big veins,
gorge-
though.
yeah, I was gonna
Why
ask
not
the
use
same
an
thing.
Abre or a
Self-expanding.
regular stent here?
Regular.
I don't like to mix and match stents. Like it's just my own preference.
Okay.
External iliac vein.
Yeah, I think the whole technology of the stent is really great for venous. You might as well utilize
Yeah.
that for
Do all the
entire
way.
venous
Watch your
Watch your
reconstruction.
face. Watch your
Yeah.
face.
Yeah.
1400.
And my understanding is they are relatively, depending on obviously everyone's pricing structure, price agnostic for the iliac
That'll be
stents
external iliac.
between
External iliac.
Abre and the BD stent.
Raul, was this patient having severe PCS type symptoms? Because those pelvic collaterals are huge.
That's what I was talking to him.
Yeah, she didn't report it. I mean,
Okay.
her main issue was really the ulcer.
Okay.
Yeah, we're gonna have a lot of overlap. I just want to make sure I don't deploy this in
this-
the
sheet.
anatomy.
Yeah.
And this is what Srini said in the beginning of the case. I think one thing people who don't do a lot of venous want to be cognizant is people stent all the way down. Just try to, just like arteries, never try to respect the profunda vein as much
Yeah,
as
we're good
possible.
there, right?
That's going to be
Yeah,
a lifeline.
looks good. It's
It's gonna
just
be a
outside the
lifeline
sheet.
in this disease.
Go up a little bit. So you don't have to do them simultaneously. You can do them kind of one at a time,
But we like the
Oh,
way you did
finally.
both hands. You know,
just to see it again.
yeah, just to see it again. You know,
Yeah, that's good.
see this. Srini has the shakes, so it's impossible for him to do. So
It's, I don't know why
Srini,
Srini
we love you. Come on, we gotta
Srini.
pick on you.
20-something
Come
thousand.
on. You said,
I think
Somehow I
Srini's-
become the
it's
old guy
perfect.
here. I don't know how I
Srini's actually like Benjamin Button. That's what he is.
All right,
PK,
let's watch
PK
it.
trained before they had guide wires. I mean, I don't know what's going on here.
Actually, you know, it's funny. I trained when we used to do 035 carotid and renal stents.
IVC.
Crazy.
Yeah.
Okay, so
IVC,
we'll do that
20
trick
something
again.
with IVC.
Okay, here's the
And
trick.
the next two were the common iliac, and the
You
next,
just need really
and the
long
next two
arms.
are external.
Yeah, I was gonna
5
say.
total stents.
Nice.
Nice.
Thank you.
Yeah.
All right, good.
Fantastic.
I love that. I love watching that. So we're gonna
Okay.
walk this
What
one
else
out. I'll walk this out carefully.
Oh, just
Oh, I did it again.
yeah,
Careful,
it's okay,
careful.
you got it.
It's a typical PK pull there.
Yeah, here it's not. I don't think it's going to be as big of an issue. Just
Overlap is too much, but
This
yeah, I don't
side,
want to
brother,
pull
you
it
want to
back.
just twist it before I pull
Yeah.
it? Okay. I think it's very important, guys. Yeah, because I did feel the resistance a little bit there. It's a little stuck here.
That's us. Yeah.
It's us? Okay, you sure?
Yeah. Go ahead.
Okay.
Just pull harder.
Okay, good. Okay. All right, good. So now we need the 14s,
Oh,
two
yeah.
14 balloons.
Got them ready.
That's a bloodbath, you're right.
During this part of the case is usually when somebody pulls something too hard, aka PK. Yeah.
Exactly.
Or the fellow.
Yeah,
You know,
literally.
You know what? I was doing DBAs with Rao, and I love doing that cutter,
Yeah.
whatever,
Valvulotome, the
valvulotome. Oh my God, I love using that thing.
Valvulotome.
Yeah, it makes it so much fun. You know, as a cardiologist, you never get to be that rough.
Yeah. I mean, you're not using those in coronaries?
All right. So again,
Don't give him ideas,
I mean,
Rahul. Yeah.
I mean, the placement is like absolutely incredible. You know, like right below where we are. And Rahul, like, you're going to go a little bit above to balloon this. Is that okay?
We're going to bring the dots right up to it, right?
Okay.
So,
The second balloon right here.
yeah.
And deflator, right?
So,
Yeah, make sure the deflators are full, please.
yeah, you're going to need all of it. These are the, because we got
Let me make sure I give you more in there.
1460s.
Yeah, I'm getting
Right there, right there, right there.
Make sure it's dilute, Vishal.
Yeah, this is diluted, right, Mikey?
Yeah, that's one. Yeah, that's one too.
Okay, I took the diluted part, so.
Okay, good.
Yeah.
Excellent. All right. And this is where, will she have pain, bradycardia, anything to worry about here?
No, I mean, she may have pain, but we already took it to 14, so we're not really
Okay.
stretching more than she had. You can just go to town.
Okay. 6, 8 atmospheres.
Like, I'd go to like 10, 12. Yeah. So, you know, people always ask, like, how do you deal with stent failure? The easiest way to deal with it is deal with it before when you put the stents, because once they go down, it becomes a
That's 12 atmospheres.
yeah. So 12 is probably good enough. She's already feeling
Ready?
it.
For 1, 2, 3.
Because once they start going down, you end up in like a vicious cycle, and it becomes really difficult to manage.
Todo bien,
So
todo
let's
bien.
talk a
10
little bit
minutos
about
más,
that. If
okay?
it does go down, is it a thrombotic occlusion usually, or is it an intimal hyperplasia?
Most of the time, it's because you don't have enough inflow, or you've missed the outflow, right? Like that's usually the problem.
Okay.
Obviously, if they're not taking their anticoagulation, that's a
Third problem.
Well, it's also very interesting that you guys use Lovenox, because we don't do that obviously in the coronary space or in the arterial space. So it's very interesting that you guys are, using
it's short term, so everyone has their own secret sauce of how long they do it for.
12.
You know, some people do it for a couple of weeks, some people do it for
Give it up for
6
a second.
weeks. You know, I usually do it till I see them in their first follow up. And then once I see them in follow-up is when and get an ultrasound and show that it's open, I'll flip them to a DOAC. You know.
So is there any chance of the stent sliding down or moving up after we dilate?
Probably not, just because
They shouldn't, yeah.
they shouldn't. Yeah.
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 You know, I think it'd be interesting as we see more use of this
Links
new
goes to
stent to see
14.
what the kind of the stenosis or recurrence or hyperplasia is going to be, because this is a different this is a very different construct than what we use in our practice for complex CTOs of the veins. We've done Viabonds and things like that, but this is a dedicated stent that's got a a partial PTFE thing. So it's gonna be interesting to see what the thrombotic or the hyperplastic issues are going to be.
Well,
We don't know yet.
Yeah.
Yeah, exactly. They haven't
Which one?
released the
I'm not
data
paying
yet
attention.
for the
I'll
study.
pay
The
attention.
study's
I'll
out, right, in
find
terms
out.
of, but the failure and sort of the secondary
14.
stuff we
12.
haven't seen quite yet. So we'll
Exactly.
Oh, yeah. We'll see what they want to do. We'll see what they want to do.
here we're gonna have to really go to town. You don't have to go together. You guys can go.
Yeah.
Up.
So question, does this stent
we'll see
ever
what they wanna
shrink
do.
when you balloon it or no?
It's not supposed to. Yeah. You can get it to infold a little bit, sort of like the normal self-expanding stents, where you can get them to shorten a little bit. I don't know if you can really elongate it too much, but
That's good to
it's
know.
more so at the deployment. But the ballooning
So
part,
we can do
unlike a
10
wall stent, it
minutes,
doesn't change.
14.
And
It's
fracture
maybe.
rates of these stents?
It is pretty hard to fracture. Although again, I think they only have 12-month data. I don't think they saw any fractures in that study. It takes bends and everything really, really well. So if you haven't seen this stent, it is pretty amazing how they got this stent to compared to the other ones that are out there. Yours isn't up.
no, PK, you're right.
Yeah.
I'm
It's
good?
interestingly,
you're
it's
right.
very
He's putting it back right now.
very
Hold on,
very
wait, PK, let's pull the sheet
conformable and
back.
relatively
you go.
similar radial force for a venous stent.
Right.
And I think Rahul brought up a great point, which is, on the venous side, because you're dealing with a low pressure conduit, with a large capacitance, your inflow and outflow is really, really important.
I'm gonna
And the
keep this
vessel
at 8.
prep here was key.
10, 12. Okay, fine.
You can take it to 10.
I did 12.
Yeah. Cool.
I'm not there yet.
It's going to look real good.
Yeah.
12.
Off.
All
Fluorescent.
right, fluorescent.
Great work, guys, so far. This is a tough case.
Yeah,
Very
it should
tough
be.
case.
And then, so for everybody at home, what we'll do is we'll do a final picture here,
And then we can IVUS off camera.
and then we'll IVUS it for you guys just to see it. And so get us at 10 French IVUS, guys.
We have the
We have it.
035.
We have the 035. Okay, good.
You guys want to pinful
Can
this?
you guys
down?
make sure?
just
Can you
pull
guys
it.
make sure to get a difficult case next time for a live case? That'd be good.
So you have to understand, whenever we invite Rahul, we're like, all right, let's find the hardest case we can. Like, look at Rahul's here. Let's do it, It's like, we love doing that to Rahul. He's always like, when I call him, he's always like, what are you doing? So this is great. All right, guys, so IVUS going in. Oh, we're doing
You wanna
a
take a
picture first.
picture? Yeah,
Picture
Let's do a
first.
venogram here. Here, you
All
want
right,
to take that
let's
side?
clean this
Yeah.
up.
PK, you want to get the whole thing in the image?
I am. I'm exactly doing that now. Hold on. So 48. Oh, I think this is as big as we go. There you go.
Yeah.
That's good enough.
You ready?
Yep.
Ready?
1. Inject.
So there's clearly a problem on that side, but
Let me get a better injection.
So what do you think? We can attach the. Here,
Yeah, let's inject.
let's
through the-
attach this. We can inject through this. 1100 psi.
yeah, part of it may be that we're actually at the edge of
Yeah.
the stent. So let's see.
1 second.
The sheath itself, right? Yeah.
Yeah.
1 second. Just doing this here.
We may need to balloon coming down the
Yeah.
other way. Yeah.
What are you guys worried about here?
We may need to balloon just the stent edge on this side.
You think it collapsed on itself?
It's an inflow issue, yeah.
Oh, okay.
Or we need to put another stent, one or the other.
Yeah.
Well, this is
Yeah, I
again.
think that's the key thing.
Yeah.
The-
Okay, ready,
the
Cindy?
inflow part. Yeah, inflow
Right.
is the key. Yeah.
Go wrong.
Ready?
Yeah.
Cindy?
He's gonna.
Okay, I don't know what happened there.
Hold on.
Oh, you didn't.
Sorry, I'm sorry about that.
Thanks, Michelle.
Just trying to help.
All right, ready? Cindy again.
Yeah, it's
Yeah.
very tight.
Actually, that's
Right,
pretty
right.
good.
Yeah, it looks good though.
Yeah.
I think we
Yeah, I
have
wonder
this.
if your sheath may have just been at the edge of the stent, maybe. not
Yeah,
long.
So
exactly. And
I think
it's-
the stent looks good, but that segment just below the
Beyond.
stent's a little bit narrowed, right?
Yeah.
Because there's a
It, does,
collateral.
it is a
So we
little
can have-
better,
yeah, let's have the left
I've
first.
just,
Yeah. Yeah. Well, I was.
Yeah.
It may just need a little ballooning just to pop a little
Yeah.
sneaky or something,
Yeah.
you know?
How's
But
the right side?
looks
Look
great.
good?
Yeah,
Yeah.
the
you
right
can
side
still see
looked great.
that.
That was
You can still see that. You still see that collateral coming off the left of that.
Yeah. Although that's also power injected, right? So
Yeah.
Yep.
Oh, it's
Yep.
power. It's power. Oh, okay.
Yeah, 1100 psi.
that,
Oh, wow. Okay.
That's
All right. All right. Never mind.
yeah.
I thought it
Oh,
was
man.
a PK push.
Oh God, that would be amazing.
So this is the vein just below the stent. Actually,
No.
actually,
There is maybe one sensation
yeah,
right
it
there.
actually looks pretty good. Okay, so
Did
going
you
up.
see a web? Yeah.
Yeah,
Just one, yeah, but
Stent looks great.
yeah.
We haven't recorded.
So that's you can see the artery behind it, right?
Yeah.
That's good.
Yep.
But you can see
Yep.
how round this is, right? Like next to
Yep.
their stent.
Yep.
Now we're up into the IVC, and
Beautiful.
Yep.
we're gonna record. We didn't record,
Beautiful,
so we just
guys.
pull back.
yeah, we'll pull back. And
We
this
should
is-
go up and just pull it back.
All right,
guys.
let's start pulling
Pull
back.
back.
And that's
Looks
native
like-
IVC.
Can we come off,
Okay.
Laura?
Native
Yeah.
IVC.
Oh.
All right.
I think you have to
Yeah,
balloon that common femoral, don't you think, Rahul? On
Yeah,
that
no,
left
I
side?
agree.
What do you
Yeah,
think?
yeah.
Would you balloon it or would you stand it, Srini?
I think you can just balloon it.
Was there a
Yeah.
web? Was there a web
Okay,
there, or
balloon.
did you guys see anything?
Yeah,
like
if
a
you go
web.
down.
I'm gonna come really slow.
There's a
Hold
web,
on.
then you want
Yeah,
to
tell-
stent it, right?
All right, here we go. Very slow. Okay, at the edge of the stent. Coming out.
That
There.
one.
Is that a web?
I don't know.
Or is
I
that
don't know.
profunda? No, that's it's not. It's not a branch,
No,
right?
it's not.
No,
That's
it's
not profunda. No, no.
Let's see
It's
how
not
it goes.
profunda.
Looks like
You're too high.
Yeah,
Looks like
I
a
think
web
We
of
could take a
some
hand
sort.
injection again. Just take a.
yeah, we can just do another hand injection. I think
Is
also
this
part
a-
of it is that it's the 33 centimeter dry seal. So like just using a 10 cc
Yeah.
injector isn't going to work, right? Or a 10 cc injection.
Maybe an
Yeah.
oblique or something there. Little
Yeah, I'm
oblique
just gonna
maybe?
go oblique. Exactly. One
Yeah.
second, Rahul. Watch your knees, brother.
That's
Okay.
good.
Laura, good.
Ready?
Yep.
Yeah.
Oh,
Oh.
jeez. It's on coronary.
Oh, you know
Flows
what?
out well.
It's flown out. Yeah, yeah. It's flown
Profunda
out.
It looks pretty good.
Yeah, yeah.
I think we leave it.
I think we leave it just leave the shit out of her.
Okay. Now
right.
we'll do the other side.
All right.
That was a bullish chase.
Yeah, just go all the way up. We'll just come back down with it.
Yeah,
Yeah,
just
we-
put back in the sheath that a little bit. Okay.
Yeah.
So again, you can see nice and round. You know, here you're double
Fantastic.
barreled, still nice and round,
Yep.
right?
Looks great.
And then
You know, I love the fact that it's an IVC stent. You don't have a double barrel up there. You know.
so the only thing
Nice.
is, I'm wondering if we should stent a little bit higher up on the IVC because it looks a little wonky here, right?
It does.
Tapers down up
It's a
there.
little
yeah.
narrowed. Yeah, it's a little
Yeah.
narrowed, guys.
And then maybe because
You
here
see the
you can
renal
see
veins? Yeah.
the.
Maybe start up higher at the atrium SVC junction or IVC junction and pull back.
Because that's
Yep. Let's
Yeah.
record. Yeah, record.
1 second. Stop. Let him.
Stop. Restart. Okay. Record. Okay.
Because
Pulling back
maybe
from the
that's the
atrium.
whole. Okay.
So this is the IV. That's all. This,
Where are we? That
here.
looks
No,
odd.
we're right. No.
Yeah, there you are.
What is that?
I don't know.
That looked terrible.
I think it's just collapsed. I think she's a little
Correct.
dry.
It's just the
I think
respiratory
it's the whole
variation just
thing,
collapses.
Rahul.
Yeah.
I think it's
I
the
think it
whole
just
thing. You know, you'll. I think you're gonna chase you're gonna be chasing. This,
Yeah,
you know,
I
if you
agree. I
stent
think-
higher.
Yeah,
Yeah.
that's my concern too. I think
Good.
you can see it moving, so it's clearly not a fixed lesion. So I think she's just a little dry.
Yeah,
Give us
respiratory
a
variation.
good
Yeah.
wide open fluids, guys. Give her a liter.
Yeah, and then I think we're
Yeah.
good. But
Yeah, let's
I,
just take
this-
a final shot.
Yeah, final
Yeah.
shot. I think you're good.
Here you go.
You want to do your?
Yeah.
Actually, you want to take like a 25?
Yeah, can I get a...
Yeah, just
That's
take yeah, like 50-50. You don't even need to
Yeah.
do full strength.
All right.
You wanna do
so
yeah, we'll do half
again,
and half.
I mean, I want to thank, you know, as we do
Can I
the
have some?
final shot.
All right, you know what?
I mean,
Yeah, go.
Srini and Kumar, I mean, thanks so much. I mean, you guys took
Keep
2
going.
hours of your day. I can't
Well-
appreciate you enough, and the audience, you know, really appreciate your comments.
Well, can I have another 20?
You know, and you know, I'd like to invite all of you out there. You know, everybody in this room is going to be at NYEVS this year. You know, Srini is one of the
Can't bring this
directors.
to get as
Rahul is
much.
directing the venous
Yes,
and the
gonna
pulmonary
bring this up.
embolism course this
I'm just
year.
gonna bring her up. So you were
So
leaning on
it's
it, so
just
don't-
incredible how the conference is going to be. We'd love to see all of you there.
Just trying to get as much.
Cases
yeah,
like this obviously are going to be discussed, and you know, we look forward to seeing all of you there. For the fellows, there's also a fellows course and an aortic boot camp associated with it, and we also have a lot of industry sponsored courses.
Are we on regular?
It's on
DSA?
DSA.
Yeah, DSA.
Yes.
It's on,
Yeah.
it's on DSA. Let me just change the
So
filter.
final shot, God willing.
Either. Oh, okay, there we go.
Beautiful.
That was
Wow.
beautiful.
Beautiful.
Beautiful, guys. Beautiful,
Great job, guys. Great job. Great morning, Case.
Amazing.
great.
This is really going to help
Well,
her. This is
thank
really
you,
going to help
thank
her.
you.
Yeah.
Well,
Yeah.
thanks so
job.
much again, you guys. Before we sign up, Rahul, thank you, man.
Of course,
thank
yeah,
you
yeah.
very much. Our team, thanks for your great nursing and tech. And we'll see you guys next month in May. We've got another fantastic case lined up, and I appreciate all of you. We'll see you again. Take care, guys.
Thank
See you
you.
guys. Be safe.
Thanks,
Thanks,
Bye-bye.
guys.